Good evening, friends. It is a big privilege for me to host yet another important session of the academic activity of the IAGS Prime, which is a fortnightly program showcasing the best of the talents in national and international arena. Ladies and gentlemen, I have the honor of introducing our president, Professor Sunil Papat, who has been taken over as the president is the most pressing time. He took over when the corona peaked up, and then we had in between some physical meetings, and again it has become a challenge to run physical meetings. So sir has been trying hard to meet up the requirements and the minimum mandates of the IAGS academics, and he has planned another 2 or 3 programs coming up, lined up with various specialities. Ladies and gentlemen, Professor Sunil Papat is known to all of you. For people who are newly joining today, it's my responsibility to keep him introduced. He is chairman of the Nidhi Hospital. He is an ardent minimally invasive surgeon with special interest in foregut surgery and endotherapy. He has ascended from the member to the executive member, and he has held all the important positions in the IAGS and ascended rightly to the position of the president of the IAGS. During his tenure, he has forged important relationship with the global minimally invasive surgical society. May I have the honor of inviting Professor Sunil Papat to welcome the gathering. Over to you, sir.
Thank you, Dr. Kanagwal, for the kind words. Good evening, faculties, and good evening, ladies and gentlemen across the globe, the audience of IAGS Prime Time. I'm privileged and pleased to welcome you all to yet another episode of IAGS Prime Time. In last 2 years, we have now done more than 50 lectures on IAGS Prime Time, and after each episode, the popularity is increasing consistently. Friends, last year, 6 months, we spent on online programs because of the second wave of COVID. And then during last 4 months till December, we could do many on-site programs. Unfortunately, again, we are passing through this third wave of COVID, and hence IAGS has decided to stop doing on-site activities and has gone back to the online program schedule. Today, in today's episode of IAGS Prime Time, we are going to discuss one important topic, laparoscopic colorectal surgeries. We are going to have Dr. Keyur Bhatt from Surat to talk on laparoscopic right hemicolectomy, Dr. Ashwin D'Souza from Tata Memorial Center, Mumbai, to talk on laparoscopic anterior resection. Dr. Raj Pandian from GEM Hospital is going to speak on laparoscopic IPA. And in the end, we'll have Dr. Pradeep Jain from Delhi, who will be doing panel discussion on complications of laparoscopic colorectal surgery. Friends, laparoscopic colorectal surgery has now already completed 20 years and has become an established procedure for the colorectal benign and malignant conditions, not only for right colon, left colon, but also for complete proctostomy and pouch surgery also. And many of our patients are now coming to us with demands for laparoscopic colorectal surgery. So at IAGS, we think this is a very important topic. I would like to thank at the outset Dr. Deep Goyal for coordinating today's event. Friends, IAGS has done many FIAGS programs, EFIAGS programs during the year, and 5 FALS program on site, namely FALS upper GI, FALS bariatric, FALS colorectal, FALS hernia, and first time in the history, FALS robotics during this year. We also had a FALS oncology program going on side by side on the online platform, which will be completing this month, and we'll be having the examination online for that FALS program. We are also coming up with a master class on safe lap chole course, safe laparoscopic cholecystectomy course on Sunday, 6th of February, 11 to 5 p.m., where we will be discussing each and every aspect of safe laparoscopic cholecystectomy. And we'll have another IAGS Primetime program on 9th of February, and the details of which will be informed to you very soon in due course of time. Friends, because of COVID pandemic, we had to postpone IAGS National Congress from February to 9 to 12 June. And that is going to be organized in one of the most beautiful town of Andhra Pradesh, Rajmundry. And we are all very eager to welcome you at Rajmundry. I will now request Dr. Kanagwal to start today's proceedings. Very much.
Thank you, President. We have the honor of having to listen to the most eminent national speakers, and our President has chosen the best of the best colorectal surgeons across the country for today's program. Today, we are going to touch upon three important colorectal resection techniques, one on right hemicolectomy, the other one on anterior resection, and the other one is the laparoscopic IPAA. So, ladies and gentlemen, may I have the honor of inviting Dr. Keyur Bhatt. Dr. Keyur Bhatt is an eminent GA surgeon with special interest in colorectal surgery. He is the director of the SIDS Hospital and Research Center, and he also heads the Department of GA, HPB, and GA Cancer Surgery. Dr. Keyur has done his surgical training from the most eminent Maulana Azad Medical College and Dr. G.B. Pant Hospital. And he is instrumental for the past 15 years working on various advanced laparoscopic and advanced GA oncology resections. And he has been instrumental in setting up a single super specialty hospital in Surat for the GA surgery. And later, he also is the founder member and pioneer of South Gujarat Surgeon Society. And he serves as a zonal representative of the South Gujarat in Gujarat State Chapter, so the Gujarat State Surgeons Chapter and the ASA banner. Ladies and gentlemen, may I invite Dr. Keyur to share his experience on the technique of right hemicolectomy. Over to you, Dr. Keyur.
Thank you so much, Dr. Kangarwal sir, and thank you everyone for inviting me to this presentation. And at the outset, I would definitely like to thank upon Dr. Professor Sunil Popat sir, the convener, the honorary secretary, and the coordinator of the program today for organizing such a wonderful event and inviting me as a speaker. So without wasting time, I am proceeding to my today's talk of laparoscopic right hemicolectomy. Before that, I would like to give you the greetings from my team of SIDS Hospital. This is today's photograph with Republic Day celebration in the morning. So laparoscopic right hemicolectomy. So we all know the basics. I'm not at all going into the basics of anatomy, but still I'll be touching upon the certain important aspects during the surgery which should be taken care, and the important aspect during and after the surgery. So what are the basic indications? We can always remember C, that is one is cancer, one is a cecal cox, one is a cecal carcinoid or appendicular carcinoid, the Crohn's disease, cecal volvulus, or the amoebic or cecal necrosis and leading to perforation, which are the main indication of doing a laparoscopic right hemicolectomy or open right hemicolectomy in our part of country. So how do we prepare our patient for laparoscopic right hemicolectomy? So I would say if we are doing the surgery for the emergency setting, then definitely we need to balance the fluid and electrolyte for the patient. If the bowel is obstructed with the IC junction pathology or cecum or ascending colon pathology, then the nasogastric decompression is a very good thing to do in order to facilitate the laparoscopic resection. However, there is no mechanical bowel preparation is needed for any sort of planned right hemicolectomy surgery. Correction of anemia, especially in case of a carcinoma patient of a right colon who tend to have low hemoglobin levels, is desired. And in our setup, we always try and maintain the hemoglobin level of 9 before any planned laparoscopic surgery, especially colorectal. Perioperative systematic antibiotic we usually start on the day prior to the surgery. And obviously, we finish our checklist with the preoperative anesthesia checkup with the cardiopulmonary stuff and serum protein and PTINR level. So coming back straight to the OR room, the position of the patient, in order to do a good laparoscopic surgery, one must always have a very good OT table which facilitates the different position of the patient, because in laparoscopy, position of the table at times act as a good retractor. So it can be achieved with the different positions that will be required during the surgery. But generally, to start with, we start with the head low position, and usually the patient is kept 30 to 45 degree of right up. And the surgeon is typically standing on the left side of the patient. So is the assistant and the camera holder, who will be standing on the left side. At times, if it is needed, we do ask our assistant to stand on the right side with the monitor on the back of the surgeon. So basics first, the resection lines. We all know what is the anatomy of the patient, but this is not what exactly it looks when we open the abdomen. So we need to reflect the entire colon along with the momentum upwards, and that is always facilitated with the head low position, so that one can see this particular anatomy of the colon. And what our target should be, the ileocolic, right colic, and the middle colic vessel visualization, because our ultimate goal is to complete this particular surgery, and that is possible only by visually completing the entire field of surgery that we are going to do. At our institute, we always follow medial to lateral approach, whether it is a benign or a malignant condition. We don't change our approach. So we always are sticking to the same condition what we do for any indication. We identify the vessel, you score around the mesentery. Depends on benign versus malignant, but we still would like to go higher up and ligate the vessels. We have stick to the same practice. And once the vessels are scored, the vessels are divided between the clips or between the ligatures. So anatomical relations are very important, and these are especially important when we are operating in a thin limb patient rather than we are operating in an obese patient, because in the thin patients we have a very limited portion of fat pad surrounding the vessels, and the structures are really visible through the mesocolon. So we briefly say, and if we briefly take off the colonic mesentery or the fat pad, what we could see is the ileocolic vessels with the ileal branches behind, and immediately behind will be a gonadal vein as well as the right ureter. So these are the important structures that should be thought of once we start dissecting at the ileocolic vessel. A little above on higher side, we need to keep in mind the head of a pancreas, because that will be the area of origin of colic vessel. See over here also exactly over the duodenum from the head of the pancreas. And at the same time, there will be an origin of right gastroepiploic vessels as well. So these all need to take care in mind when we are scoring the peritoneum, especially in thin patients. And this is how it looks if we denude the fat and the peritoneum from the right colonic area. What we could be, what we'll be able to see will be the ileocolic vessel, the right colic vessel, and the middle colic artery arching over the neck of the pancreas from the below. So I have deliberately chosen a little tough case over here with the large mass with the fat volume of high, and already patient was cirrhotic, and there was significant adhesions. So one can see our technique, that how once we splay all the bowel and how we identify the vessel, you hold the left hand with the near the mass and you lift it. Whatever is lifted is the ileocolic vessel, and one can see the surrounding lymph nodes. These are the few natural adhesions many a times we find during the right hemicolectomy. We don't try and never try, in fact, to take off these adhesions because they act naturally as a retraction. Once we identify that where the vessel is situated, especially in the obese patient, that how do we score at the vessel. For the beginner, it is always better to start scoring a little away from the duodenal area, and then slowly, with the help of left hand retracting the ileocolic vessel, one can always dissect and divide bit by bit and identify the ileocolic artery and vein at its origin. Here I would like to point a small little thing that what we typically use in open surgery technique, that mixture is used to identify this kind of a fatty situation or thick vessels. So we use harmonic blades also as a mixture to facilitate dissection between the thin areas, and this will allow us to separately ligate or clip the vessels individually, which will eventually prevent any sort of complications following this surgery. So vessels, once they are clipped at the root of the origin over the duodenum, they can be divided either with the help of harmonic scalpel, or they can be divided with the help of scissors as well. Once the first step is done to identify and lifting the ileocolic vessel, the second step is to take the right colic vessels at the root. So how do we take this particular vessel, especially in this kind of how do we identify it? So again, a very simple technique: the lift the mesocolon, identify the pancreatic head, identify the duodenum, and then ask the assistant over here to give a traction on the middle colic area on the transverse colon. One can see that once we score over the parietal peritoneum of the mesentery, one can see a popping up of right colonic vessels. Over here, the key is the retraction of the assistant, who is continuously stretching and keeping the transverse mesocolon and transverse colon straight. If we go ahead in the same line, we will always find a right branch of middle colic vessel over there, and that can also be taken care in the same sitting with the same stretch with the assistant is given. Here also we are using harmonic as a mixture to facilitate the passage of clip over the other side of the vessel. Once that is done, the clip is applied and the vessel is divided. Still, the assistant is holding the middle colic, that is giving a good traction, good field, and we don't need generally fifth port. We always do right hemicolectomy with the 4-port. And here now we are dissecting the right colic vessels again at its origin, and we are denuding the vessel from its surrounding fat and all the lymph nodal mass. One can see that it is reflected and it is taken towards the uh, specimen side, and the patient side is completely denuded. Once the vessel is completely denuded, it can be clipped and then it can be divided. All the surrounding area of the vessel should be secured, otherwise it can have bleeding from the surrounding lymph nodes and small venules. Once the vessels are dealt, the third step of doing right hemicolectomy surgery is to give a score at the gastrocolic omentum or the open lesser sac. That is done again at the same level where we have done the marking, or where put an incision over the right branch of a middle colic vessel. Key step over here is to extend the mesenteric division, gastrocolic omental division on the left side in order to facilitate an easy anastomosis. Once again, over here, the assistant is giving continuous traction over the gastroepiploic vessels and the stomach, the greater curvature, that will facilitate the easy mobilization of the mesocolon inferiorly. And this is the area where one will encounter a gastrocolic trunk. At times, it is a larger vessel that needs to be clipped. Otherwise, it can be taken care with any form of energy source device. And once that area is completely cleared, the pancreatic head is visible and first part of a duodenum is clearly seen over here. We finish, this was the patient where the mass was lying a bit low. Otherwise, at times we see that the colon is sometimes stuck badly to gallbladder and inferior surface of liver. This is the area where one should always take care not to avoid or to avoid any injury to gallbladder or liver. The last part of mobilization of right hemicolectomy surgery in our step is to mobilize the ileum. So that is always done with the extreme head low position so that everything is lifted superiorly. A mesentery is poured at the peritoneum or some adhesions if at all they are there at the level of ileocolic vessels region, and we should allow CO2 to do the dissection over here. The left hand is continuously pushing the ileum and the colon superiorly, and the right hand is dissecting exactly at the Tol's line. And one can see the clear-cut demarcation of gyrotas fascia, and over there is a gonadal vessel which is seen. And if we continue in the same line where we have started dissection on the right lateral aspect, meet the line where we have done the dissection from superiorly. And this is how the complete mobilization of ascending colon or the cecum is done. For anastomosis, there are different varieties and types of anastomosis of right hemicolectomy is there. But most famously or most commonly we are using at our center is the Barcelona technique. And how do we do a Barcelona technique? Resection is we put a small score. Once we deliver a small we put on supraumbilical region, we put a scoring on ileum as well as colon, and this is the area where the future anastomosis is going to lie. We use a 80 or 75 load blue load linear cutter cartridge, and this is how the both the lumens of transverse colon and ileum are approximated. It is always desired to use a wound protector device in order to minimize the wound related complication and granulation. And we always put a small stitch, probably this is for the satisfaction, but we always put a small stitch at the end of staple line. And the enterotomy is again taken at the four corners. Stay suture is taken. Another stapler is kept. Here the care is taken not to fire the stapler on the mesentery, and we need to always make sure that both the enterotomy side is taken on the other side with the specimen and is fired to complete the anastomosis. Once the anastomosis is done, we put a small gauze and wait for a couple of minutes so small ooze generally disappears, and hardly it requires a suturing on the stump side. A little word on extended right hemicolectomy. It is just an extension of the surgery where instead of right branch of middle colic artery, the middle colic artery is taken at the root, and the ascending branch of descending or a left colic artery is usually taken in a similar fashion to the right branch of middle colic artery. And the anastomosis is completed in a similar way from ileum to the descending colon. So coming to the complications of surgery, what most annoying complication during the surgery that we have seen at many other places as well is bleeding from the right colic vein. Especially this happens even in open surgery also with the little bulky growth and a tight abdomen or a small tummy, and assistant being little more vigorous. So this at times is a notorious bleeding. The bleeder tends to retract within the pancreatic head, and it messes up the field even during the laparoscopic surgery. So one should always take gentle care of right colic vein because it is very short as compared to middle colic and the ileocolic vessel, and especially if the mass is there near the ascending colon. So this should be taken care with a little ease in order to avoid the injury. If at all there is an injury, obviously we need to over with the help of pulling suture. At times there could be injury to duodenum, to the pancreatic vessels, and as well as ureter, especially in the thin limb patients. I've seen one case during the surgery. I had to rush that accidentally the surgeon clipped the iliac artery instead of ileocolic artery. So that could also happen sometimes, especially in a very thin limb patients. And lastly, anastomotic leak is the last complication that any would like to have, but it can happen. But if it happens, that our target or our experience says that it is always better to take down the anastomosis and do a double barrel stoma rather than redoing the anastomosis and doing a proximal loop ileostomy. We have seen in many patients referred to us from different centers, but they are carrying more morbidity, the proximal diverting stoma. So we always prefer and make a double barrel stoma. Post-operative care is pretty simple for this particular kind of a surgery. We always use an intraoperative or a pre-operative, I would say, TAP and RS block. More than 60 to 80 cc of diluted sensocaine is generally given in the TAP plane. So that helps in perioperative management of pain. Almost 24 hours, all the patients are pain-free following the surgery. We have stopped using any epidural anesthesia for lap or even lap-assisted surgeries after usage of TAP block. Patient is usually ambulant on next day and is usually started on liquids depend on his peristalsis status. NG tube and Foley's are generally removed on next to next day. And we never use any nutrition, IV nutrition support for right hemicolectomy, especially planned or malignancy patients. And average day of discharge is either day 4 for a planned or maybe day 5 or 6 for the emergency kind of a patients. Follow-up is all depends on the etiology. For benign, obviously, you don't need a significant follow-up. For all malignant, we all know we need to follow the protocol of every 3-month ultrasound and 6-monthly ultrasound with a CT scan every yearly. Just before I finish my talk, just current status of literature I had I had gone through recently, that recovery after intracorporeal anastomosis in laparoscopic right hemicolectomy, a systemic review and meta-analysis, they said that there is no extra benefit of doing intracorporeal versus extracorporeal anastomosis. This study they have studied more than 950 patients. Another study of lap versus open anastomosis for right hemi, there is no extra added advantage. At times in this study, they tried to say that it is saving a cost little bit in terms of hospital stay, but the cost of stapler, obviously, in a country like India, which is definitely making sense to us. Hospital stay is a little less, 1 day or 1.5 days is less, where the intracorporeal anastomosis is done in compared to the Barcelona or lab-assisted technique. But again, that is a matter of a little debate in a country, especially like India. Another meta-analysis that was comparing hand-assisted laparoscopic right hemicolectomy versus open right hemicolectomy for the right-sided colonic cancer, and they again showed this was published in 2020 May only, that both the arms, the results are in all aspects are comparable. So lap versus hand-assisted, both are very good. Lap right hemi with CME, a standard of care, it is a pretty good thing, and it is a very good technique to do a laparoscopic right hemicolectomy, where one is always lifting the ileocolic pedicle, going behind the colonic mesentery, separating the duodenum and pancreas, leaving the gyrotas fascia behind and reaching up to the hepatic flexure. That's a good technique. They are showing very good result with this particular technique of right hemicolectomy, looking the duodenum from behind and creating the window. It is a good technique for oncological outcome as well. And last but not the least is the neoadjuvant stuff which is happening nowadays in colorectal, and people are trying neoadjuvant chemotherapy not only in rectum but also in the other colonic cancers. And the preliminary data from 2020, they said that the results are quite good. And recently, another big study of neoadjuvant chemotherapy in patients with unresectable or locally advanced centers, study from China, and they said that neoadjuvant has made many inoperable patients operable, as well as the multivisceral surgery has reduced the number of viscera to be resected for non-rectal colonic cancer. So this is coming up, looks like probably in a big, better and bigger way. That neoadjuvant treatment for colonic cancer other than rectum is also probably making its way. So at our hospital, our data, we had more than 1,100 colectomies, and almost 55% are right hemicolectomies. 70% are malignant, 30% is benign, and so far we had luckily only 3 leaks, that is 0.47% from 460 right hemicolectomies. Our average length of stay is around 5.6 days, including emergency surgeries for right hemi. And our lymph node yield in right hemi for the specially malignancy is around 13.5, and of which around 90%, 89% cases we do lap. 11% are open, and they are straight away open from the time of incision. We have hardly converted any laparoscopic surgery to open surgery till date. So those, my book on complication in GI and RPB surgery, it's available on Amazon, and you can visit my YouTube channel with laparoscopic surgery for all laparoscopic GI surgical videos. Lastly, I would like to invite everyone to this summer. We'll be moving to our another 200-bedded multi-speciality hospital, and I'll just share the invitation card once it is done. Thank you. Thank you so much.
Thank you, Dr. Kayur, for a brilliant exposition. President, do you have comments, please?
Yeah. Kayur, excellent talk. I enjoyed it thoroughly. You covered nicely the anatomical part, the graphical details, the surgical technique, and the complications aspect also. One important observation I made was using the TAP and RS block, and not many centers are using that routinely, but I think it's a very good thing to do, and a lot of analgesics you can avoid in postoperative period.
Correct.
Yeah. What is your experience on CME and CBL?
Sir, we always try and do CME in all our cases. In fact, the last paper that I quoted, the CME as well as the critical window of duodenum, we always go with the same technique, and it is really very avascular and nice plane. Even in presence of large growth which is situated in the ascending colon, then also it is easier to find the plane, and along with the every lymph node, every aspect is cleared nicely with both the techniques.
Yeah. And you said Lupok Henle, do you always tackle it from above, or you tackle it from below also?
It depends on the case, but generally we take it from above.
Okay.
Yeah.
Because I thought in CME mostly we take it from below.
Take it from below. Yeah. Yes.
And CVL, when do you do complete vascular ligation? CVL in all the cases or in extended right hemi only?
For every patient of benign or malignant, sir, our practice is same. We do it at root. All the vessels are to be taken at the root near the pancreas at its origin.
Okay. Here, just 1 week ago, we were having our international webinar with our UK colleagues, and we discussed a lot about closure of mesentery after right hemicolectomy, whether it's to be done or not to be done. So, what is your thought on that, and what is your practice?
So I know that there's a lot of debate is going on, especially when we move from open surgery to laparoscopic surgery. But to my experience, the last 15 years, I have not closed a single defect of mesentery. Not only in right, but any bowel surgery, we don't close.
And it hasn't led to any increased number of obstruction.
No, touch wood, no complications because of that.
You said you have experienced very few leaks, but what is the leak rate internationally? I mean, if you go by multivariate analysis,
So our
acceptable leak rate.
Yeah, even if it is around 2%, it is still acceptable. I would say right hemicolectomy is not a very demanding or a difficult surgery in compared to left hemicolectomy or low anterior resection. Reason behind having a little low anastomotic leak rate at our center is that our threshold of doing a stoma is very low. So whenever we are doing a morbid patient, or whenever we are doing a patient with a less than 2.5 albumin, we don't do anastomosis. Our policy at institute institute is very clear, less than 2.5 albumin, and original hemoglobin less than 8 of a patient of a right hemicolectomy, we always put a stoma. We close stoma in early, maybe around 20-21 days. So probably that is the reason that we have faced a little less number of leak in compared to the other standard randomized control trials as well.
Yeah. Raj, you have any question or comment?
Nice presentation. Two things I want to clarify now. So since we are talking about the malignancy for right hemicolectomy, benign as whatever says good. But now the CMA with CVL has become standard of care. And it has been proven that there is 50% of increased outcome for the patient. So if you talk about right hemicolectomy, I mean colon resection for any colonic tumor, whether you do right hemicolectomy, extend right hemicolectomy, or left hemicolectomy, extend left hemicolectomy, or subtotal colectomy, it should be like nominated like a CME with CVL. Yeah.
CME with
and
CVL.
as you correctly told, even if it's a large tumor occupying the right colon, if you go in correct plane, the CME, that is what we say, it's initial retrocolic, retromesenteric, endoscopic tunneling.
Yes.
You go over the duodenum and you over the pancreas and separate the mesocolon from the pancreas. Of course, you are taking the whole superior mesenteric vein and it is relaxed so that you come back, and if you do that, the traction will not be there. So because the traction is released, the injury to the small vein is less. So once you don't do that, if you go in middle that, there is high chance of bleeding. What you told is exactly correct. So that is the one that they have found that releasing the correct plane between the torus fascia and the mesocolic fascia, there is a avascular plane, so that the traction of the mesenteric vein and the branches, that is tributaries, are lessened, so that easily you can go and tackle the complete vascular, that is central vascular ligation can be taken. And another thing, if you are planning for right hemicolectomy, you have to make a taut at the iliocecal junction. You just lift it so that you will see the iliocolic vein. And once you have done that, easily you can go, but you have to come like a little bit 5 centimeters below the iliocolic origin, so that you can go to the along the medial border of the SMA or the anterior border of the SMA. You can go and take a central vascular ligation.
Complete pedicle.
Yes, complete so that you can your lymph node will be mold. So our aim is to have a maximum lymph node. Better lymph node. And particularly extend the right hemicolectomy, you have to take the level 6 lymph node. For that, you have to take the right gastroenteric vessels. And the important thing is the lymph node around the middle colic vessel has to be taken. So now the literature has they have found that the main culprit for the recurrence following right hemicolectomy is the nodes which is close to the middle colic vessel. So these are the
pancreas.
Best I want to guess.
Near the neck of pancreas.
Yes,
Peripancreatic are the recurrence reason.
Yes. And another thing you said, the bleeding may be there. Once you don't, usually you can't typically identify the gastrocolic vein from below while you are going from below. From above, as very easily you can identify. There are some communicating vessels will be there. Because of the neovascularization, we don't know, but there will be communicating vessels from the anterior surface of the pancreas to the mesocolon. So while doing so, sometimes we may miss that, and there may be bleeding. And once there is a bleeding, you will miss the plate. That is, these are the two things you should keep in mind. But otherwise, exactly what you are told is correct. And the extracorporeal or intracorporeal, nothing much difference. If you have
doesn't make any difference.
Yeah, if you have an expert, if you want to get expert by doing intracorporeal anastomosis, and the patient is affordable, the main thing is if the patient is in a room, AC room or deluxe room, that we go for intracorporeal. Patient in general, what I go for extracorporeal, like 60-40 only. So what you are told is correct, because there is no much difference. They make only 4 to 5 centimeter incision in the midline, and I feel it is better to do extracorporeal intracorporeal, because I have seen after 6 months or 1 year, once you follow the patient, you can't see the midline incision, because we go through the umbilicus. If you go through the umbilicus, you have extra 2 centimeter length for
Yes.
your plane. So if you should not go around the umbilicus, go through the umbilicus, you will have, because that we learn by doing a initial while we are starting the surgery, sills colectomy. So what we did, we just open the midline, or if you are doing sill section, we go circumferentially open the umbilicus, so that we have a 2 centimeter length. We found we have
Raj,
extra 2 centimeter length.
Raj, thank you. We'll have to cut short a little bit. Ashwin, you have any comment?
Excellent presentation, excellent technique. Really enjoyed it. One of my own difficulties that I have sometimes is if the mesentery is very fatty. So I'm not able to see that window, avascular window below the ileocolic when going transmesenteric as you should. And also for people who are beginning, I think maybe easier to go inferior to superior a little bit sometimes and identify the duodenum there. So if we have difficulty going transmesenteric, that sometimes helps me out and could help the beginners also with this procedure. Otherwise, technique is excellent.
Thank you.
Great talk.
Pradeep?
Yeah, basically, as a standardized protocol in our institute, we always go from inferior approach. Because if you do the inferior approach, you just safeguard the entire retroperitoneal structure and the head of the pancreas and duodenum. And it is always easy to take a central ligation after once you have made a full tunnel from below. So we never go from the transmesenteric approach. We always go from the inferior approach. And it always helps us, and it's much faster, I believe. In the initial period, it is a bit difficult and cumbersome, but once you have done enough number of cases, then the inferior approach always appeals much more and much safer, I believe.
Okay. Keyur, what were your port positions? You said you used 4 ports. So what were the port positions?
I'm using a little odd ports than standard recommendation. So umbilical is a standard port that we put, as Dr. Raj has rightly said, vertical through umbilicus we put so that that can be extended for anastomosis. My left hand working port is usually depends on the location of the cecum or the location of the tumor, but generally it is on the left iliac fossa. And the right port that I put on the right hypochondriac near the 9th intercostal, and that is always a 10 mm port where I will be using key clip applicators for applying all the vessels clip. Now the assistant ports varies. It is sometimes for a thin lean patient, it goes into the left iliac fossa also. And for an obese lady or obese patient, we put it on the right anterior axillary line so that in future that will be utilized as putting a tray. And that also gives the traction.
Okay. Thank you. Dr. Kanagwal, over to you.
Sir, I think we will have to go to the next thing. Sorry for cutting short very important discussion, but then we have something very important. Dr. Pradeep Jain sir also compiled up, and we'll have all the speakers as panelists. So we have more questions coming through the platform. Also, we'll have it together. Ladies and gentlemen, I will request Dr. Keyur also to stay with us. In the meantime, we move on to the next topic, the LAP IPEA, the most challenging one of the colorectal surgeries. May I have the honor of inviting Dr. Rajapandian. Dr. Rajapandian has been, from the inception, has been under the leadership of Professor Palanivelu sir, the most eminent laparoscopic surgeon in this part of the country and across the globe. And from the beginning, Dr. Rajapandian has been instrumental in creating, being the founding lead of the colorectal division. And they have been doing very important academic work. They also contribute for the DNB in GA surgery and multiple fellowship programs. And as of date, Dr. Rajapandian, to his personal credit, he has 44 original publications to his personal name. And of course, GEM has more than 400 publications together. So, ladies and gentlemen, may I have the honor of inviting Dr. Rajapandian to highlight the importance of the technique of IPEA. Over to you, Dr. Raj.
Am I on the screen?
You are fine, sir.
Okay, shall I start? Am I audible?
Perfectly audible, and we are able to see your PowerPoint.
Okay. Thank you, Dr. Kanakavel, for the nice introduction. And my personal thanks to Dr. Sunil Pappat and Isra Mukherjee and Deep Goyal. And my special thanks to Kanaka to make me to talk this at an early stage. Okay, my topic is I am going to talk about the laparoscopic total proctocolectomy with ideal pouch anal anastomosis. Full thing I'm going to talk about the laparoscopic. So it is feasible. What is the indication? If you go to the indication, mainly it is a IBD. Next is FAP, attenuated FAP, and HNPCC, and the double malignancy. So we do like 50-50 for most of the time. So this is the picture of FAP and attenuated FAP, how it looks in endoscopy. So these are in acute severe ulcerative colitis or made for toxic megacolon. So initially, these patients will have a total colectomy with endoileostomy, then followed by restrictive proctectomy with ileal pouch anastomosis, and finally there will be pouch, ileostomy reversal. So coming to the pouch, we have various type of pouch. The main pouch, what we are talking about is a J pouch, which is very commonly used and easy to prepare the pouch. So whereas the other pouch, you have S pouch and W pouch, of course, lateral pouch is there, but it is rarely performed in this laparoscopic era. In the open era, depending upon the patient and depending upon the experience of the surgeon, they used to make this S pouch and W pouch. So now we are going to concentrate more on the J pouch. I think most of the surgeons here will be doing the J pouch, and we always do the J pouch. And so far we have done more than 250 cases, and we never found any difficulty, and it was the best pouch, I would say. And usually the pouch will be around 12 to 15 centimeter. I'll be showing the video. Before that, just a few points regarding each pouch. The J pouch is, as I said, it's very easy and quick to create the pouch, and it's most commonly used worldwide with all the colorectal surgeons. And the problem is it can have a bowel frequency higher in J pouch when compared to S and W pouch, particularly W pouch, where there will be difficulty evacuation of the bowel. Whereas in J pouch, there will be more number of frequency, but over a period of it to get accustomed. At least minimal 4 to 6 times patient will be passing motion after the J pouch anal anastomosis. And by using antidial agent, it can be controlled. S pouch, you have a long efferent tube of 2 centimeter extra. So in case if there is a tension for the pouch to reach the anal canal, so you can go for S pouch. But W pouch, as I said, is very capacious. It has a good function. Only problem is more than 50% of the patient may have to have a self-evacuation of the stool. That is the one problem. But the another problem is it will take a long time when compared to J pouch, because the hand suvan, you have to do S pouch and W pouch hand suvan technique. So it's very rarely used nowadays. So now coming to the laparoscopic TPC and various method of J pouch formation. What are the standard method? Usually we do everything laparoscopically. The pouch will be formed extracorporeally because we will be taking the specimen, and through that, whether ileostomy site or through this property, a small incision, we'll take out the ileum and make a J pouch formation, which is the standard of hand, even though you do laparoscopically. For order the other form of making a J pouch, you can make an intracorporeal J pouch using laparoscopic portion. I'll be showing, and you can use transanally. You can use the pouch formation. So these are the intracorporeal pouch formation. So once you have made a pouch, the technique usually double stapling technique, that is circular stapler, or you can do a hand-sewn pouch and anastomosis. There are 2 types of pouch and anastomosis. One is circular stapler, another is a hand-sewn. So coming to the various type of instruments, this is standard instruments. You need a harmonic or ligature or anything you can use. And stapler, of course, you need an endo GI stapler and circular stapler. I'll be showing the theater setup. Mostly the theater setup like this, semi-lithotomy portion. Particularly for a TPC, you need a 2 monitor. One will be on the right side of the patient, one will be on the left side of the patient. So it depends upon where you want, whether you want to mobilize the left colon first or right colon first. It depends upon the surgeon's preference. But I always prefer you do the difficult part first. So you'll be mobilizing the left colon first. The port position as is shown here, it will be like this. The port position is there. So I always used to say my juniors and the PGs, that is TPs is nothing but a combination of extended right hemicotomy and the ultra low anterior resection. That's all. So this is the combination. So once you able to do a ultra low anterior resection and the extended right hemicotomy, then that completes the total proper colorectal. So I'll be showing the videos. So once you finish the mobilization of the right colon and the left colon and the rectum in the TME plane, after division at the level of the pelvic floor, that is at the anorectal junction, usually that it should be there be some anal transit zone will be there. So whatever you do, you can't divide. So you can go even in intersphincteric area and just above, just 1 centimeter above the dentate line, you can go and divide. So once after the division, through the ileostomy site, depending upon the patient contour. If it is a female patient, I used to take through the ileostomy site. If it is a male patient, it will be difficult, so I don't want to disturb. So through a small financial incision, you can take the externalize the colon and do a pouch, then reintroduce and make a circular anastomosis. We'll be showing it. So the pouch will be formation by endo-GA situs anastomosis, and pouch and anastomosis will be using a circular stapler or coronal handsaw. So this is the theater. This is the team setup. You can see the operating surgeon. You can see the assistant surgeon and then assisting nurse. So this is a video I'm just showing. This is a just 3-minute video. This I am starting from the like an anterior resection. So this is mobilizing the left colon first, sigmoid colon and the rectum. So now I am going entering the TME plane. You can see the vessels clear, nerves clearly. So I am going for the always high ligation. This is the case of male patient, FAP. So IMA is delineated, high ligation of the IMA after clipping and dividing. So once you divide the IMA, medial to lateral resection, preserving the retroperitoneal structure, that is glomerular vessel and the ureter, and of course the nerve. Now we are going for the IMB. So along with the IMB, there will be ascending branch of a left colic vessel there, that has to be also clipped. So IMB is divided at the inferior border of the pancreas near the DJ flexure. So medial to lateral mobilization over the serratus fascia are completed. Then the lateral mobilization of the sigmoid, the rectosigmoid junction. So if you are in the correct pin, there will not be any blood loss at all. Now we are going to the lateral and anterior mobilization of the rectum. The TME plane, circumferentially, now we are dividing the rectosacral fascia, Valdes fascia. Once you do up to the pelvic floor, through the suprapubic incision, I am just dividing the rectum at the anorectal junction. So you need minimum at least 2.5 to 3 centimeters from the anal verge for the circular stapler head to accommodate. So now the spinning flexure is mobilized. You can see the inferior border of the pancreas, spleen. So now I have done the ultra-low anterior section. Now I go to the right colon mobilization. Right colon is typical of what we are doing with the IETA initial retrocolic retroanesthetic endoscopic tunneling technique. So once you do that, keep a gauze piece over the duodenum. So to prevent injury to the duodenum while you are tackling the vessel. So now I am tackling the ileocolic artery and vessel. You can see the duodenum. So ileocolic artery and vein separated, separately divided. You can see the ancillary passes head of the pancreas. So over the duodenum and over the head of the pancreas, separate the mesocolon, divide the right colon, right branch of middle colic and left branch of middle colic. Sometimes there may both right and left branch will be arising from the one trunk. So in that case, you have to divide right and left branch separately, not go for the trunk. So now the hepatic plexus is mobilized. The final this branch of the middle colic. Now the specimen is out through the suprapubic incision and the extracorporeal pouch, J pouch is formed. So you have to make around 15 centimeter and make a enterotomy over the apex of the pouch suck it out and clean the pouch. You make a window on either side. You should not make a bigger one because you have to pass the anvil inside. So before that, using a 60 blue stapler, I'm just making. So usually, if you feel very thick, you can use blue. Otherwise, nowadays we are using white stapler because to prevent bleeding. You can use white or blue. If you are using blue, you have to make sure there is no any bleeding inside after firing. So the anvil is passed at the apex, and we have to fix it with the suture. So if it is bigger, you make an interrupter suture, then close to it, make a circular stitch. So anvil is passed inside, the pouch has gone. Now we are making the pouch and anastomosis. And make sure there should not be any twist in the pouch. Because there is a twist and the tension is there, then there will be a problem of the ischemia can happen to the pouch. Usually very unlikely. Keep a DT and diversion. Always we do a diversion diastomy for all the pouch cases. So next I will show a video in acute ulcerative colitis. This is like a emergency, like semi-emergency. This patient was like more than 25 days, has been treated with all type of medication for severe ulcerative colitis. Was using albumin is very low. It's not at all improving with this electrodemia. Then we have to go for a emergency TPC with IPA and with the diversion diastomy. But in severe some cases, usually go for a colectomy. Like a semi-emergency, if you feel the patient is okay, you can do for a TPC IPA and do a diversion diastomy. So this fellow is a young fellow, 30-year-old male. He was hardly like 30 kg. After this, now he is 45 kg. So now the left colon has been mobilized. We have come to the right colon. The lateral attachment of the right colon is divided. The hepatic flexor is getting mobilized. Now the important part of the rectal mobilization. So circumferentially should be mobilized up to the levator ani. And in that case, usually you will ask the perineal surgeon to push from the anal canal so that we can have a proper division at the anorectal junction. You can see from the perineal surgeon has to do a rectal examination and make sure where exactly the rectal division is happening. So exactly anorectal junction has been done. So through the ileostomy site itself, we have removed. You can see how severely affected colon has come. Probably going for a multiple ulcers was there. So in this case, we have to wash. So we are just checking the pouch length. You can intraotomy, probable site for the apex of the pouch. Using white stapler, very thin. 60 white endo-GA stapler. Usually 3-5 is enough. Sometimes 4 will be there. So before we have to just wash the pouch. So annual has been fixed, got inside through the circular tape and anastomosis, the pouch and anastomosis. So always make sure there should not be twist in the pouch. So now this is the area where we are going to keep the diversion must happen. This is another patient of severe ulcer with a toxic marathon, which we did a total colectomy. This is a specimen of total colectomy. And this is the patient there. The same patient after 6 months, I'm doing the restorative proctectomy with the pouch and anastomosis. The previous toxic marathon for which did the total colectomy with the diversion ileostomy, endoileostomy. After 6 months, the same patient I'm doing the restorative proctectomy with the ileal pouch and anastomosis. You can see how it looks. Since we have done previously laparoscopically, there is no obvious adhesion at all. If you have done same open method, you will see severe adhesion to even identify that the pelvic would have been frozen. The same TAV plane I am doing. But unfortunately, the same patient was having a remaining rectum also, there was severe ulcerative colitis. So I am dividing the superior rectal artery in the vein, then entering the TME plane. To enter the TME plane, so entire mesorectum, because all edematous boosting patient was on taking steroids and the Zoram. It's a male patient. So when we did proximal, he was from 80 kg, went for 40 kg. Then he regained the 40 kg and he was 80 kg when I was doing this restorative proctectomy, I mean the proctectomy. So it was a bit difficult for him. So entering the TME plane, posteriorly, laterally, and anteriorly, circumferential dissection should be there. So if you are in correct plane, there it will be like avascular, even though in an inflamed rectum. So anteriorly, just I am preserve the renal fascia. So we asked the perineal surgeon to do a PR and with the rectal clamp, we clamp and see where the possible area of anorectal junction division using circular GA stapler. So now the rectum is out through the ileostomy site. So now the ileostomy is there, that has to be removed, and the rectum has to be removed through that. So he has developed a small parastomal hernia. So through that we have removed the ileum and we are making the pouch outside. So we are making enterotomy of the possible site of the pouch head. Using white stapler, I'm using 1, 2, 3, usually 3 or 4, depending upon the size. So minimum, I feel like 12 to 15 centimeters is enough. The anvil is introduced and fixed with the 20 PDS. The remaining open end of the ileum is removed using stapler. Now after introducing, we are just doing the pouch and anastomosis. In very low places, it will be very difficult. You can't even show the anastomosis. So just that showing the donut is good. After keeping a DT, again you have to do a diversion diastomy. Diversion diastomy of the same site. So this is a 1 minute video just how to make removing the colon, that intracorporeal J-port formation.
Raj, can you conclude, please?
Yes, this 1 minute I will conclude. So the pouch we are forming intracorporeally. Intracorporeal J-port formation. Transanally, and the pouch is brought down transanally, and hands-on anastomosis is done for this patient. So there was no any incision at all, except the diversion diastomy. So I'm not going to waste this showing all these things. So I would like to conclude, like lab TPC-IP is feasible and safe, and becoming a standard of care for FAP and other severe ulcerative colitis. Laparoscopic J-port formation is feasible and should be practiced in high volume center where expected is. Thank you.
Thank you very much, Raj. Excellent presentation and videos. Any questions, Pradeep?
Sir, Pradeep is just setting up his PowerPoint.
Okay.
So we can ask
have a
Ashwin
discussion
and
at the
Kayur. Yes, sir.
So we can go on with the third lecture and later
Yes,
on we
sir.
can have discussion.
Because time is running.
Yeah.
Sir, please share your screen.
Yes.
Dr. Ashwin,
Yes, sir.
can you try sharing your PowerPoint?
Yeah, sure.
Ladies and gentlemen, now I have the honor of introducing Dr. Ashwin. Dr. Ashwin has been part of the colorectal division of the Tata Memorial, and he has to his credit many important, I would say, the colorectal. He belongs to the mainstream multidisciplinary colorectal team, and they have something called like a disease management group, like something like our multidisciplinary team. And it is a group of surgical oncology, JA oncology, radiation oncology, medical oncology, and the entire pathology team along with the radiologist team. And to his credit, has more than publications. And in fact, he also concentrates on various complications, and he is part of the study group. And he has worked upon almost all aspects of the malignancy, from the translational research to the minimally invasive and the most advanced upcoming science of the colorectal sciences. Ladies and gentlemen, now I have the honor of inviting Dr. Ashwin to speak about the right technique and the practice of standard of practice in the laparoscopic anterior resection. Over to you, Dr. Ashwin.
Thank you. Thank you very much, sir, for that introduction. Can you see my screen?
Yes, sir.
And am I audible?
Perfectly audible, sir.
Great. So I'm going to tackle this topic by first briefly stressing on the principles of anterior resection for malignancy. Then I will add the laparoscopic component and finally end with a video. When we speak of rectal resection for cancer, it is almost synonymous with total mesorectal excision, a surgical approach introduced by Professor Heald in 1982. With a single change in approach, he was able to reduce local recurrence to less than 5% and increase the survival to nearly 80%, something that was impossible with any adjuvant therapy at that time. If you want to appreciate the incremental benefit of TME surgery over conventional rectal cancer resection, rectal resection, we can look at the earlier neoadjuvant radiation trials, the Swedish rectal cancer trial and the Dutch TME trial. If you look closely at these two trials, the trial arms are exactly the same. So why did the Dutch repeat the same trial done by the Swedish? And the reason for that was there was almost no TME surgery in the Swedish rectal cancer trial and a standardized TME approach for the Dutch TME trial. Looking at the control arms of both these trials, we see that just by incorporating TME as a standard, local recurrence is down from 27 to 11%. And if onto this we add neoadjuvant radiation, that comes down further to just 5%. Now, total mesorectal excision is of two types: a total mesorectal excision for a low rectal cancer or mid rectal cancer, and a tumor-specific mesorectal excision that is only applicable for upper rectal lesions. TME involves complete resection of the mesorectal envelope within the mesorectal fascia right down to its termination at the anorectal junction, but tumor-specific mesorectal excision requires only 5 centimeters of mesorectum to be resected distal to the tumor to constitute an oncologically adequate resection. The double stapling technique introduced by Griffin and Knight has been revolutionary in sphincter preservation. This technique involves performing the TME right down to the level of rectal transection, dividing the rectum with a transverse stapler, and then performing an anastomosis with a circular stapler, as we have seen in the earlier videos for pouch. Using this technique, we can go right down to the anorectal junction, but the limits of sphincter preservation in anterior resection of the rectum have advanced much further than this. We can push the boundaries to perform an ultra-low anterior resection where the TME is continued transabdominally into the intersphincteric plane, opening up or mobilizing the upper anal canal. Then the rectum is transected transabdominally within the anal canal, and we perform an ultra-low anterior resection. This has been pushed further to the ultimate effort at sphincter preservation with the intersphincteric resection, which can be either partial, subtotal, or total, depending on the extent of internal sphincter resection. Here, the TME is completed, entering the intersphincteric space from the abdomen, and this is coupled with a perineal approach, dissecting right down to the dentate line, which constitutes the embryological extent of the rectum. So this represents the zenith of sphincter preservation in rectal cancer. How much distal margin do we really need? Way back in the earlier papers, less than 1 centimeter was shown to be adequate. That has come down to less than 5, less than 2, but that's where we draw the line. A less than 1 millimeter margin is actually the definition of a positive margin. So at least 1 millimeter of tissue is required. When appreciating sub-centimeter margins, one has to realize that these are not mucosal margins. These are full thickness rectal wall margins, and they only apply in cases of a total mesorectal excision. Once the entire mesorectum is resected, then only these sub-centimeter margins are oncologically adequate. They don't apply for the tumor-specific mesorectal excision, where we do need at least 5 centimeters of distal mesorectum to be resected to be considered as oncologically safe. So the minimum standards for an oncologically safe rectal cancer resection is a TME which is complete or at least near complete, and negative margins, both distal and circumferential. After we are able to achieve this, then only sphincter preservation has relevance. We cannot compromise these first 3 requisites to save sphincters. And if we can achieve all this in the minimally invasive approach, then it is safe enough. So that puts into perspective laparoscopic and robotic surgery for rectal cancer resections. So is minimally invasive surgery safe for rectal cancer? And we have to go back and look at the trials that have been published to support this. We have two very good trials, the Korean trial and the Color-2 study. They are totally supportive. Both of them have come out with their long-term results, and they do support laparoscopy as an oncologically safe approach for rectal cancer. However, 3 trials pointed out some areas of concern. The MRC Classic trial had some issues of CRM positivity, and 2 trials back-to-back published in 2017, the ACROSOG and a la carte trials, laid some concern on the non-inferiority of the pathological criteria associated with laparoscopic rectal resection. So with this evidence, is laparoscopy in rectal cancer a safe approach as far as oncological outcomes is concerned? If you look at the 3 trials that raise concern, the first, the MRC Classic trial, the results at 3 years, the same trial, the same patients, and the CRM, slightly higher increased CRM positivity in the rectal cancer group did not actually result in an increased local recurrence. And if you look at the results at 5 years, again, the same trial, the same patients, but the conclusion is totally different. And it confirms the oncological safety for laparoscopic surgery, both for colon and rectal cancer. The ACROSOG and the a la carte trials also have published 2-year survival, disease-free, and local recurrence data for their groups of patients. And they also, like the MRC trial, did not see any increase in DFS or local recurrence associated with laparoscopy. Of course, both these trials have not been powered to assess this as an endpoint, but it does give us some idea, as all these 3 trials that raise concern for laparoscopy in rectal cancer did not result in inferior long-term oncological outcomes. So is laparoscopy really safe? Is open surgery in rectal cancer also safe? So the safety of surgery is defined more by the surgeon and whether or not these essential components of oncological adequacy are able to be achieved. If a particular surgeon or group is able to achieve results with laparoscopic surgery, of course it is safe, and there are trials to support it. So yes, it is safe, but it should be performed by experienced surgeons, high volume centers, and whether we do laparoscopy or open, we all need a continuous audit of our results. What about robotics in rectal cancer? Another minimally invasive approach. This is the largest trial, the rollout trial. There is a small phase 2 trial from Korea, but we'll just look at this data. This aimed to compare laparoscopy versus robotic surgery for rectal cancer with the primary endpoint of conversion. Did not show any difference. None of the secondary endpoints also showed any difference. As an exploratory sub-analysis, they did find some benefit of robotics in obese male patients for the low rectal tumors, but the study again was not powered to say anything conclusive on that endpoint. At the TMH, we looked at our own data comparing laparoscopic versus robotic TME over an 8-year period, and we looked to see non-inferiority of robotics. If you look at this comparison of about 407 lap versus 120 for robotic, the patients are largely equivalent in terms of baseline characteristics. We did see a higher number of sphincter preservation procedures in robotic group. More of the ISR we prefer to do robotic, as it gives very good exposure for the transabdominal intersphincteric part of the dissection. Looking at our operative and pathological outcomes, the hospital stay was a little longer in robotic, conversion 2% in lap and no conversions in the robotic group. CRM positivity 3.7 and 4.8%. Distal margin positivity, just 2 cases in the lap group. Operative and pathological outcomes fairly well comparing with all the published data. And if you look at comparative survival, local recurrence and disease-free. There is no difference really between the lap and robotic groups, and the absolute rates of 3 and 5 year survival compare well with published literature as well. On a multivariate analysis to look at factors that do influence disease-free survival, you see that just the node positivity, signet ring histology, and the type of surgery, sphincter preservation versus APR, had any bearing on disease-free survival. The approach, lap or robotic, did not have any influence on recurrence or disease-free survival. I'll go to the video to share our technique. We have seen excellent videos on total proctocolectomy. So I chose a video to stress on nerve preservation techniques for lap DME, because this is one area that is often overlooked. So this video has sound over, so I'll just let it play and then we can discuss later.
This video presents the technique for laparoscopic.
I'll just include the sound, just a minute. Yeah, I think that should be it.
Sound is coming.
Yeah.
Total mesorectal excision in an abdominoperineal resection with emphasis on autonomic nerve preservation. Our patient is a 30-year-old male, status post-chemoradiation for non-metastatic adenocarcinoma, 1.5 centimeters from the anal verge with right levator involvement. The surgeon uses the right two ports, one as the working port and the other for counter traction, while the assistant provides two-point traction through the left two ports, beginning by elevating the superior rectal artery with the left hand at the sacral promontory and the right hand elevating the IMA closer to its origin. The right leaf of the rectal mesentery is then tented to determine its exact point of attachment to the undersurface of the artery. The peritoneum is then incised at this point and the incision continued both proximally and distally. Right at the outset, it is important to recognize the position of the superior rectal artery, the location of the right hypogastric nerve, the plane of dissection posterior to the artery, and the presacral plane which is to be avoided. Dissecting just posterior to the superior rectal artery, the right hypogastric nerve is dropped down. As we proceed posterior to the artery, the origin of the left hypogastric nerve comes into view. We can see the location of the right and left hypogastric nerves as they leave the sacral promontory and descend into the pelvis. The rectum is then retracted anteriorly and dissection continued just outside the mesorectal fascia. We appreciate the position of the right and left hypogastric nerves, the mesorectal plane of dissection, and the presacral plane which is to be avoided. Dissection is then continued at the root of the IMA. We do a little medial to lateral dissection first to visualize the left ureter, which can sometimes come very close to the root of the IMA. All the fibrofatty tissue is dissected off the root of the IMA, beginning on the right side, proceeding onto the anterior surface, completely skeletonizing the artery till the first sigmoid branch. This completes the nodal dissection. The left colic artery is then elevated. We can appreciate the position of the IMA continuing as the superior rectal artery, the left colic artery, and the location of the left sympathetic trunk, which needs to be dropped down. We dissect just posterior to the left colic artery to drop down the branches from the left sympathetic trunk. Dissection must be very precise here to remain in the perfect retroperitoneal plane. We then turn our attention to the root of the IMA. Only the right side is dissected at this time, isolating the IMA from the fine sympathetic fibers of the abdominal aortic plexus, which cross the aorta. Dissecting just outside the adventitia of the artery, the IMA is isolated and encircled with a mixture fossa. No dissection is done on the left side at this point. The artery is then clipped and divided. After division of the IMA, the superior rectal artery and the left colic artery are elevated to give excellent access to the fine branches from the left sympathetic trunk, which are precisely divided to drop down the trunk. Adopting this technique minimizes sympathetic nerve injury at this level. The colon is then mobilized in a medial to lateral fashion. We can see the left gonadal vessels here. And then the lateral attachments of the descending colon are taken down by sharp dissection in order to mobilize a sufficient length of colon that can be brought out without tension as an end stoma. Rectal mobilization is begun first on the right side. The right hand of the assistant holds the cut edge of the peritoneum at the sacral promontory, retracting it to the left and anteriorly. With this traction in place, the left hand of the assistant retracts the upper rectum towards the pubic symphysis, providing the essential 2-point retraction to facilitate posterior dissection. Working at the sacral promontory, the posterior mesorectal plane is developed. We can see the location of the right and left hypogastric nerves. The mesorectal dissection, which is performed in a U-shaped manner down the right side, across and up the left side, and the presacral plane, which should be avoided. By dissecting in this fashion, one proceeds just outside the mesorectal fascia, at the same time preserving the presacral fascia. Precise posterior dissection between these two facial planes ensures a complete TME and an intact presacral fascia, which protects the pelvic splanchnic nerves. Posterior dissection is completed till the pelvic floor. As we go up the right lateral side, we can appreciate the pelvic splanchnic nerves as they course around the rectum and tent the presacral fascia. The assistant's right hand then retracts the upper rectum to the left and posteriorly, while the left hand, working through the left lower port, retracts the bladder peritoneum anteriorly. We then proceed with the anterior dissection by incising the peritoneum on the bladder. Lateral dissection is done only after both the anterior and posterior planes are defined. As the anterior dissection proceeds, the right seminal vesicle comes into view. With the right hand on the upper rectum, the assistant then retracts it to the left, pushing it posteriorly, and at the same time applies countertraction to the bladder diametrically opposite using a fan retractor. With this traction in place, the surgeon's left hand retracts the mid-rectum medially. This maneuver pulls the nerve fibers of the inferior hypogastric plexus medially. If one dissects laterally, they can be injured. The safest way to proceed is to communicate the anterior and posterior planes, which have already been developed, around the lateral aspect of the rectum where the plane is least well defined. In this manner, the inferior hypogastric plexus can be protected. While it is important to protect the nerves, it is imperative that all mesorectal tissue is resected till the endopelvic fascia is visualized, completing the rectal mobilization on the right side. The assistant then retracts the upper rectum to the right while maintaining the anterior retraction on the bladder to begin mobilization on the left. The peritoneal incision is completed and the left anterior plane is developed. Once again, we appreciate how accurately the lateral plane can be defined once both the anterior and posterior planes have been developed. As the lateral dissection proceeds inferiorly to the region of the left inferior hypogastric plexus at the posterolateral aspect of the left seminal vesicle, we can appreciate the position of the left hypogastric nerve, the left nervi erigentis as they end in the inferior hypogastric plexus, and our plane of dissection beginning anteriorly posterior to Denon-Villiers fascia, going medial to the plexus and continuing into the posterior plane that has already been defined. Proceeding in this fashion, posterior to Denon-Villiers fascia, medial to the plexus, and around the rectum, one reaches the left levator, thereby completing the left rectal mobilization. Anterior dissection is performed just posterior to Denon-Villiers fascia, continuing till the superior aspect of the prostate. A point of proximal specimen transection is selected on the descending colon, the bowel divided with a laparoscopic stapler, and then exteriorized through the stoma opening. The perineal dissection is then completed and the stoma matured to complete the procedure. The patient had an uneventful recovery. The urinary catheter was removed on the first post-operative day. An ultrasound confirmed a nil post-void residue, and a histopathology confirmed an R0 resection with 13 negative nodes.
So thank you. That's our technique with emphasis on the nerve preservation. The stapling and splenic flexure, I think Raj Pandit sir has shown very well in his lab TPC report video.
Thank you very much, Dr. Ashwin. President, your comments, please.
Thank you, Ashwin. It was one of the most excellent dissection I saw with the monopolar cautery, particularly spatula. And this technique is very famous in our Far East friends, particularly Japanese surgeons and Korean surgeons. And I'm very happy that in spite of having all the energy sources you have the access to in Tata Memorial Hospital, you are still showing it with monopolar spatula. So wonderful dissection. I think let us go to last presentation, which will cover the question answers. Dr. Kanagoyal, is it ready?
Yes, sir. Nathan? Nathan?
Actually, I'm back.
Yeah.
Can you
Okay.
see my
Sir,
screen or no?
One moment,
Yeah, we
sir,
can.
and I will have the honor of introducing you. Dr. Pradeep Jain is a specialist in GA surgery and GA oncology, and he right now is with multiple hospitals. The most premium one is the Fortis Delhi, and he has done his MS and MCH from the Maulana Azad Medical College and later on to the GB Pant Hospital. And he has more than 3.5 decades of surgical experience. And he has spent long years in the SGF of GA Oncosurgery in Rajiv Gandhi Cancer Institute and Action Cancer Hospital. Presently, he is the director and head of GA and GA Oncosurgery. And he also specializes in bariatric and advanced minimal access surgery. Right now, he is practicing in Fortis Hospital, Shalimar Bagh, Delhi. Over to you, sir, for this panel discussion.
Okay. The thing is, first of all, I like to apologize that I'm not able to share my screen. There's some setting problems in my computer. I've been trying for the last half an hour or 1 hour, but I'm not able to do it. So I had converted this and sent it to Nitin. He will be sharing my screen, but a few of the videos are not running. So I'll, in advance, I want to apologize for that. So, but I'll try to generate some discussion on the complications of laparoscopic colorectal surgery. Nitin, can you share from your end?
He has shared the slide.
Share, can you see?
We can see, yes.
Okay. So just a minute. I can't see that. I can't see my, whatever you're sharing, I'm not able to see that. Are you sharing?
Yes, he is sharing.
But I'm not able to move it from my end.
No, he will be moving it.
So, but I can't see that on my screen. Nitin.
Dr. Pradeep, I would request you to use your mobile or one of the other device to get into the same Zoom so that if there is some mismatch.
Now Zoom call, okay. Should I leave meeting then? Just a minute. Zoom call. I'm in the meeting. I'm back to the meeting. Yeah, I can see. Yeah, you are, I'm clicking it now. Okay, so I cannot control it from my side. You will just move the slides. So can I have the first slide? It's not there. It is not coming on my screen. So let me do one thing then. Let me do one thing. I see my presentation from my side, and I'll keep on discussing. Basically, we have seen all the three techniques of all major surgeries of laparoscopic colorectal surgery. So I'll be just discussing few points about the complications. So just a minute. So we all know that there can be a lot of complications while doing this laparoscopic surgery or in the post-operative period. The majority of common complications are bleeding, visceral injuries, ureteric injuries, nerve injuries, or stapler-related kind of problems. And the post-operative, you can have an anastomotic leak, bleeding, or in the later on, they can have functional bad outcomes in the form of LARS or the urogenital problems. So first of all, I like to go on the bleeding, intraoperative bleeding. So these are the questions posed to the panelists. Can I pose this question to Dr. Ayur first? What are the most common sites of bleeding while doing the laparoscopic colorectal surgeries?
Yes, sir. So as we had been discussing since an hour or so, most common site of bleeding in right hemicolectomy will be the right colic vein, followed by the right colic pedicle, and we can definitely have a bleeding from the gonadal vessels as well. And similarly, if we are doing a surgery of LAR or a left hemicolectomy, we can still have bleeding for, near the root or near the pedicle from the vessels.
So Dr. Kayur, I mean, while doing the right hemicolectomy, I think the most common site of bleeding, the most common site of problem you can have is a gastrocolic trunk.
Gastrocolic trunk.
So this vein of Henle. So, I mean, how do you, I mean, what steps do you take to make sure that you are safeguarding that part of the dissection and you're not damaging the gastrocolic trunk or Henle's vein? So what do you do exactly for that?
So the best concept for doing a right hemicolectomy is to, as we have discussed, that go into the CMV plate. So that will definitely minimize the chances of injury. And second thing, what one can do is rather than using buzzing the current and cautery, we should go layer by layer and dissect the mesentery layer by layer. That will always lead to identification of loop of Henle, and then you can safeguard it and clip it and divide it if at all, if it is needed to prevent the bleeding.
Okay. So this is a question to Dr. Rajapande now. Now, what are the risk factors of having bleeding? I mean, the bleeding from the vessels or bleeding from the staple line or from presacral fascia. What are the risk factors you can enumerate which can lead to bleeding from
usually obese patient, pre-op neoadjuvant chemoradiotherapy, when long patient was on steroids in case of IBD, these are the risk factors I would say for bleeding. Even if you are very careful, there may be such patient, particularly patient on steroids for a long time, and you are taking, and there's a stapler anastomosis, you can expect bleeding from the stapler line. So even if you are doing a side-to-side anastomosis, always just see that after stapling, put a scope inside and see whether there is any bleeding, or if you are doing extracorporeal side-to-side anastomosis, also just see the anastomotic line, how it is, the integrity is there, any bleeding is there, if there is bleeding, you have to take a suture. So sometimes even after taking suture, later post-op you can come across bleeding. So it's bleeding is very important, particularly if you're taking, I mean, if you're using stapler, whether it's endo-GA staplers for side-to-side anastomosis or even circular stapler also anastomosis, depending upon the vascularity. So I would say this. Our patients, sometimes patients taking for like antiplatelet for a long time, even though you stop for 4 days or 5 days. So that patient can go for a bleeding even during surgery or post-op.
So is there any predilection of bleeding in patients who's got atherosclerosis, a lot of atherosclerosis, patients who's got cardiac disease?
Yeah, cardiac disease, those who are taking antiplatelets.
Okay. And even if the patient is not taking antiplatelet, there was a study which is which has quoted that the patient who's having CAD, the coronary artery disease, they have more bleeding from the staple line even if they are not taking any antiplatelets. I don't know what is the reason, but
this sounds correct. Also, the patient who's having thrombosis, there should be bleeding. So microvascular, I don't think so. Okay.
Okay.
Probably.
And now, Dr. Ashwin, I mean, can you tell us how to stop the pre-sacral venous bleed? If you have gone too deep and had a lot of pre-sacral bleed, so how do you tackle that?
Yeah, so usually this happens when the plane of dissection in the posterior plane has been missed and we go too deep. So I think the first step here is to put in a gauze piece and give pressure. Second point to remember is that these are venous bleeds, so they are low pressure system. So we get a lot of help by just temporarily raising the pneumoperitoneum to about 16, 18. So that will give a little bit increased pressure and this the bleed. The next is I would not actually try to control the bleeding before further mobilizing the rectum distally, because the moment we release the pressure on the bleed and then retract the rectum anteriorly, that is what opens up the vein again. So first step, put pressure. Second step, raise the intra-abdominal pneumopressure, and then mobilize the rectum further down. And then once the tension on the vein is released, then the hole is actually quite small. Sometimes that stops just with pressure. Next, we can use bipolar or any other energy device. And even then, if it is a flush opening onto one of the sacral foramina which bleeds from there, what I found helpful is put some surgical hemostat like a Surgicel or a Surginet piece there to hold it down and apply the bipolar or even the monopolar current onto that. So that sort of forms a seal onto the hole which comes out directly from the sacral venous plexus. So with these techniques, I think I have been able to control most of the bleeds.
Have you ever used cardboard pins? Because some people like to, use these pins to, press over the sacrum and stop the bleeding.
I've never needed to use it. I know it's described in the literature, but I've never actually needed to use
those things are only in the open technique, I feel.
Yeah.
It's like bone wax, you can use this bone wax. And what he has to.
Does the bone wax work? Because if bone wax works, if you the
bone
surface is totally exposed.
Yeah, temporarily. Bone wax, just bone wax. Okay. But what he said is like Surgicel and keep pressing for a long time. You just give pressure over that, keep a Surgicel. Mostly it will stop.
Yeah, because this is
you just give more time. That's all.
Yeah, just time, because
just give time. Don't bother. You just give 5 minutes, 10 minutes, even 15 minutes, or even 20 minutes. Just after 20 minutes, you can't see.
So there actually, I had a few videos of bleeding from different points. So they're not running. So I'll be skipping those videos, and I'll just ask a question of: is there any? This is to Dr. Rajapandan again.
Yes, sir.
Is there any role of routine intraoperative endoscopy? Do you do it routinely, or you just do it actively?
No.
And how does it
after
help?
After the anastomosis, you said for looking for the bleeding at the anastomotic site.
Hello. Yes.
Yeah. What do you mean by intraoperative?
Intraoperative, after making the anastomosis. After doing the anastomosis, you always
we don't do usually.
Okay.
But post-operatively, I have one case after shifting the patient to the HTU, we come across a bleeding perirectally. So I have to do a sigmoidoscopy, and then there is a bleeding spurt, a small spurt from the anastomotic side. So just we use bipolar, just use a clip. And that's all. So, we routinely don't use intraoperative scope to look for artery. Usually there will be mild bleed and it will get soft. So usually first time and the next day or day after, the patient will be saying, I have passed some blood or some dark color. They will say that will get stopped. So but one case, the patient was taking steroid. So after the anastomosis, third day we have to reopen. So that was following a subtotal colectomy. So there was iliosigmoid anastomosis. So we have to go in and we have to suture. Just for suture, we have to dismantle. We have to do a enterotomy. We have to make just one stitch on that because it was a spurt. So that patient was taking steroid actually. So then we have to close it so we could manage that.
I think most of the people are not using this endoscopy after making the anastomy, because most of the time it's not available in your OT, because these endoscopes are lying mainly with the gastroenterologist, not with us. So, but there's a lot of, evidence in the literature is there. When you do the routine endoscopies after making the anastomosis, the chances of bleeding is less, because most of the times there's a oozing from the staple line and you can control it then and there only. And in addition to the watching for the bleeding, there's another very good point that you can visualize the anastomotic area and you can see whether there is some ischemia there or the proximal conduits of absolutely ischemia, or there's some, badly placed staples. You can visualize that and correct then and there only. So the chances of leakage also decreases. Do you agree with this, Dr. Pandyan? If the facility is available in your OT, will you use it always?
I won't do routinely, because my anastomosis will be ultra low. Okay. Like most of the time, it will be probably within 4 or 5 centimeter. And as you said, there will be, if you do anastomosis, because the circular strip is only 2 pin is there. So you expect some bleeding depending upon. For example, if you are using, I used to have a golden stapler for dividing the rectum. Okay. So depending, most of them it will be thickened. So after that, once you say, after division, there will be bleeding at the staple line, and it will get, it will get resolved within once you're planning for a circular stapler, it will get resolved. So if it is obvious stapler, you will put a clip on the divided end of the rectum. So inside a circular stapler, because only 2 pin row is there, there is always a little bit bleed will be there, but it will take some time to get coagulated on itself, unless the patient is having some other problem. Particularly, as I said, patient is having some chronic steroids or some other disorder like the collagenous disorder. So that patient, you can expect some bleeding. So we may have to tackle it then and there. So in that cases, you can use, yes, it will be useful. Another thing, you may giving little bit more pressure by putting air or carbon dioxide, so that itself can little bit decrease the intraluminal pressure. So it is increased so that it can decrease the bleeding side. That is also. Okay. Another thing, even if you see a bleeding, what we are going to do by endoscopy. So you need a person who can tackle, you can put a clip, or you can spray some hemostatic powder on that. So these are things. It's an intraluminal bleed, how you are going to tackle it. So you are seeing, you just give a wash, but mild ooze, it can stop. So always, immediately, if you after doing a circular stapler, definitely there will be bleeding, but you need not worry about it. It will get stopped.
No, I'm talking about Dr. Rajpanda. It's not only for bleeding I'm talking about. I'm talking about you can see the condition of the conduit also. Yeah, condition of the conduit, but if there is ischemia of the mucosa itself, because I feel it is unlikely. So it will take some time to show the ischemia. So next day, if you do a scopy, you can visualize the mucosa. For example, esophageal anastomosis, the next day, after second day, we can go and see the ischemia of the mucosa. But immediately, you can't see the ischemia. It will take some time. So if there is ischemia necrosis immediately, but obviously you will be seeing in the serous aspect as well. So most of our anastomosis end to side, so I don't expect any ischemia unless. So I have one patient which had a ischemia, but there was no perforation, but there was no leak. But I was suspecting something else. So we did a rectal contrast that there was no leak. But a DT said I can have a bad smell. I suspect some ischemia. I went and said that there was a ischemia of the proximal colon for a long distance, but still there is no leak or there is no perforation. It was very difficult to divide. There is no obvious, but the ischemic segment was there because there is no meandering mesenteric vessel for particularly that patient. So it's a very thin lady, so careful, but still there was no mesenteric meandering vessels. So that was going for ischemia. So I have to just refashion and do a colostomy for that patient, even though there is no leak for that patient. But there was ischemia. So that case, it will take some time, but not immediately. So I think very point made by you, Dr. Pandyan. Actually, just want to ask from Dr. Ashwin and Dr. Kayur also whether they agree with the same points, or they will like to do this intraoperative endoscopy.
We don't have actually intraoperative endoscopy for at Tata as yet. as most of the anastomosis are actually low down, so the integrity of the anastomosis we can usually feel with the finger in maybe 8 out of 10 cases. Vascularity of the proximal colon, we actually see very well while putting the anvil inside. So we can actually see the bleeding there. And as Dr. Raj Pandyan also pointed out, that the intervention options there in the OT also are very limited. Vascular clips, injection of saline adrenaline, all that is very limited in the OT.
Okay.
So utility, ideally good to have, but in 8 times out of 10, I think we can get away
It's not
without.
required.
Yeah.
Absolutely okay. That's a fair point you made. So
we do
Dr.
have,
Pandyan,
we do,
notice
yeah,
something?
we do have facility of, scopy in our own theater as well. And this gastroenterologist theater are just next door. But as Dr. Pandyan has rightly said, till this many cases in this many years, it required only in one case where we had after 24 hours, we did right hemicolectomy, and unfortunately the guy bled significantly to drop to a level of 5 hemoglobins in 24 hours. So we had to scope him and put a clip on the anastomotic site with endoscopy, colonoscopy. I mean, other than that, we had quite a few LAR bleeds who had bled significantly, even up to hemoglobin fall of 1 or 2. But eventually they stop. We don't do anything, and usually they stop from the rectal anastomotic bleed. We don't even suture them. We don't suture them.
Okay, then we proceed to the next time and talk about the ureteric injuries. So Dr. Kayur, what are the sites of ureteric injuries, most common sites of ureteric injuries?
So, for if I talk of right hemicolectomy, it will be definitely near the if it is mistaken during the dissection of the ileocolic pedicle. There is a place, or in case of a large mass which is there in the ascending colon region, which has already engulfed the ureter while we are creating the CMV plane, and that could lead to a mid-ureteric injury on the right side. So
what about the left side?
Left side, usually the left colonic mass are not in near to ureter, but one can have definitely injury while doing the LAR or while doing ligation of a pedicle of ileocolic vessels. I mean superior rectal vessels. There is a place where one can mistakenly injure the ureter on the left side.
Okay, and Dr. Ashwin, what are the risk factors basically to have ureteric injuries? What are the factors which lead to more injuries in the ureter?
So I think just lack of familiarity of the plane, I think that is the main thing. Ureteric injuries we almost never see for a standard TME, because if you follow the plane that is well defined around the rectum, the ureter is actually quite far. So even while doing the medial to lateral, even a very fat patient, we would not search for the ureter if we are within the plane and we can see the Todd's fascia intact. So in a thin patient, of course, it's visualized through the retroperitoneal fat. 2 areas I would like to point out. One is when dissecting at the root of the IMA, sometimes the ureter can come very close. So that one should be careful there. And at the pelvic brim, there one should not mistake the plane and go laterally. The issue of ureteric injuries is more for extended TMEs when the tumor has actually transgressed the mesorectal fascia. So that is when we will actually do ureteric dissection and isolate before we go ahead.
No, you're talking about only malignancy, Dr. Ashwin. The thing is, many people can have the history of extensive diverticulitis or the large masses, or patient who had multiple pelvic surgeries. So aren't these patients are high risk for ureteric injuries?
Absolutely, sir. But at Tata, I'm afraid we have absolutely zero experience with that. So I'll ask Dr. Raj Pandyan to take up that question.
Yeah. The ureteric injury, as he mentioned correctly, usually in standard normal TME you will not come across unless, as you said, if the tumor is very bulky, rectosigmoid. So that preoperative we will always discuss with the radiologist whether we need to have a stent for this patient. Very rarely, probably 1 out of 20 patients we may have to work preoperative stenting, particularly for malignancy. So if it is a big tumor, upper rectum or rectosigmoid, where it is difficult for the left side ureter injury. And I feel the ureter injury at TME is very likely near, like within 4 centimeters of a vesico-ureteric junction, where it comes little bit close. So you, after the posterior dissection, when coming to the left lateral dissection, you should be very careful. After the anterior, that is the place we could not identify the ureter. So still that plane you will be seeing the ureter is going. You know the ureter is plane, but there is a plane where you can't identify the plane of the ureter where it goes, particularly in an obese patient. And another thing is, this is for malignancy. And as you correctly told, if there is a difficult case of multiple diverticular disease or with a colovesical fistula, yes, definitely I go for. And patient with a previous surgery for endometriosis, particularly in female. So a lot of, you will not identify the ureter, so it's better to have a ureteric stenting pre-operatively, that is before starting, so that even if you injure the ureter, so we can just suture it on table with a stent. So I think over a period of 20 years, so we have done 3 cases like that. So on table ureteric injury, if you identify, we can just suture it. But sometimes we make the ureter injury. One case, there was an injury to the ureter near the vesico-ureteric junction. I called the urologist. So while removing for clearance of the tumor, then we purposely divide, and he did at the end he bore his flap. So young patient, so like that.
So I mean, you favor prophylactic stents in difficult patients.
Yes, definitely.
So I mean, it's a question to Dr. Kayur. Is there any significant, robust evidence that these stents, the prophylactic ureteric stents, really make any difference? They really decrease the chances of injury, or is it the identification is more easy? I mean, it's easier to identify rather than preventing injury. Is there any robust evidence in the literature?
So definitely, if you are using ICG, same thing, no? So you can use ICG to identify the ureter. So that comfortably you can identify the ureter. So definitely there is evidence that you can avoid injury if you are using a preoperative like ICG or fluorescence ureteric stenting.
I mean, this is what we feel. Sometimes we have subjective feeling that these can be very helpful. But in literature, if you see carefully, there is no robust evidence to suggest that it will prevent ureteric injury. They will make the injury identifiable. And rather, sometimes they lead to high incidence of AKI or the UTI, or there can be transient hematuria, or the cost is more, the operative time is more. So it's a controversial point. Not everybody will like to go for prophylactic ureteric.
Not for all cases, only for difficult cases where you feel that maybe a ureteric injury, well, because very close, as initially said, the ureter is very well away from the tumor of the segment, there is no need. But if you can't see, so particularly if you are going from medial to lateral near the pelvic ring, the ureter will be coming very close. So your dissection, maybe by dissecting the tip, can injure the ureter.
Okay. So every panelist think that it should be used prophylactically.
Yeah, for difficult case, not for routinely. Only for difficult case where you anticipate that maybe ureteric injury.
So fair enough. That's it's a valid point. So we proceed to. I had few videos about the nerve injuries, but right now I cannot show them because of the local problem on my neck. So I'll be skipping this because Dr. Ashwin has already shown very nicely in his videos that how to see nerves and prevent injuries. So I'll be going to ask about the anastomotic problems. So Dr. Kayur, can you really predict which patients are they're likely to have a leak? So can you have some pre-operative parameters which suggest that if the patient is having surgery, having a low anastomosis in the pelvis, they can have more chances of leak? Are there any parameters you can judge, or there is any scoring system which suggests that this person can have more chance of leak?
Yeah, so basics are very basic. Like we need to definitely look at what is the albumin level of the patient, what is the hemoglobin level of the patient, especially if you are doing ultra low anastomosis. We always cover the ultra low anastomosis whenever we are doing any anastomosis below the pelvic reflection. Even though we are doing a double stepper technique, we always cover it with the diverting colostomy or ileostomy. Especially the patient who has undergone a neoadjuvant treatment before the surgery, or the patient who is on steroid, or the patients who are already immunocompromised. So they are all pretty high chance of development of leakage. So we, rather than leakage to happen, we would cover it with a diverting stoma.
Actually, there is a very good predicting scoring system is there, which takes account of the age of the patient, gender, ASA grade, whether the patient is obese or not, whether the patient using any substance abuse is there, whether the patient is smoking or having some other addiction, neoadjuvant therapy, or patient is going for emergency surgeries, or overall the distance of anastomosis from the anal verge, or whether we are having any additional procedures like cholecystectomy along with the rectal resections, if there's a heavy blood loss, duration of surgery, all these factors are combined into a score. And if the score is more than 11, it has been shown that the chance of leak is much more if the score is 11. So if you have a score more than 11, then it is always better, as Dr. Kayur said, that it is always better to go for covering ileostomy. Right? So now this is a question to Dr. Ashwin. What are the steps you take to decrease the post-operative leak? What are the steps? I mean,
I think,
if you are making an anastomosis, what are the safeguards you're taking to decrease the chance of leak?
So they're all very basically surgical principles. First is whether or not to mobilize the splenic flexure. I think if there is any doubt of tension, complete mobilization of splenic flexure should be done. We should not hesitate to get good mobilization of the colon. Second is check for vascularity. If you have ICG, excellent, but no, not everybody has ICG. So I just cut the marginal at the level of bowel transection at the proximal bowel and look for the bleed there. Colon takes little time to change color. It actually doesn't change color on table. So if I don't see a good bleed there, then I will go back and revise, mobilize more colon. Very rarely we do see absence of arcade communication between the IMA and the SMA at the splenic flexure. I've seen it in about 2 or 3 cases. And that means from the splenic flexure, the entire colon has to be removed because there is no communication. So mobilization, vascularity, try to restrict the number of staples to transect the rectal stump. There is a study showing that more than 2, actually, if you increase every incrementally the number of staples to divide the rectal stump, the chance of leak is higher. So usually after chemoradiation, the rectum is little thickened. So I don't attempt to take the rectal stump in one stapler cartridge because almost always it never fits. So my aim here is to take just half the rectum with one cartridge, and the other half fits very well with the next cartridge. And the overlapping area of the 2 cartridges actually comes out in the donut. So essentially, I don't have overlap in the transverse rectal stapling using this approach. And that's about it. And the stoma we do for all low rectal anastomosis below the peroneal inflection following chemoradiation. These we will always protect with the stoma. The stoma does not decrease the incidence of leak, but definitely it decreases the manifestation of the leak.
Yeah, you're very, I mean, excellently described about it, and you opened few questions also. I mean, this is to Dr. Rajapandan. At which level do you ligate the vessels, whether the inferior mesenteric vein or inferior mesenteric artery, while mobilizing mobilizing the splenic flexure completely?
Yeah. IMA, the high ligation always they do. IMV at the inferior part of the pancreas. Okay. And I always mobilize the splenic flexure because so once you mobilize the penis, it's easy to come without any traction in the blood vessels. So once you put the financial incision, and even if you are doing a low AR or a high AR also, not like there is not typical high AR. Once you remove the IMA, then you have to go below the, at the junction of between the upper rectum on the or in the between the upper and the mid rectum, your anastomosis should be there because the upper rectum blood supply is little bit compromised, mainly by the IMA. It will not be from the internal iliac and the internal pudendal. So I feel that is the main problem for the leak. So a little bit low, you go for anastomosis. That's it. And always I do a sphenic flexibility. There should not be any tension at the anastomosis at all.
Yes.
And we never do a diversion diastomy nowadays, even for the ultra low. So we have formed like all our patients will have a bowel preparation. Even if the patient leak, we'll take early laparoscopic and do a diastomy. So that's just we are finding it just to maintain the.
Very important point you made, Dr. Raja Pandit, this ligation of IMV at a higher level, just below the pancreatic border, inferior border of the pancreas. I think that's the main, important point.
That is the one
a lot of
you even up to, you can bring it up to colon node, so up to anal canal, no problem without any tension.
And Dr. Pandit, don't you think you just said that you are not making any ileostomy in any of the cases? So don't you think if you are not making any ileostomy, made it a rule that you're not going to make the ileostomy?
That is only just we are going. This is only in our center. I don't advise for the others.
Yeah, I think, but
because
this
is not for the not for all cases. I would say even I feel okay. Some difficult cases. On table, if you feel even ultra low with the difficulty with another, then we go for a diversion. Yes. But so all my colon anastomosis interspecific definitely go for that. So nowadays more and more low rectal cancer we are going for like a coloanal because for the circumferential excision to have a nil CRM as Dr. Asim was clearly showing. So if you have a low, like less than 5 centimeter analyte, you can't divide completely circumferentially. It will be difficult. So you have to go for coloanal because you have a distal, at least distal resection margin more than once. My aim is at least you have to do more than 1 centimeter distal resection margin. Even though the literature says if you have a frozen section negative margin, you can do. But still, I feel. I personally feel you have to do distal resection at least 1 centimeter circumferentially, and CRM should be negative. So if that can be given only by intersphincter resection with colon anastomosis.
Okay. So about the safety of the anastomosis, Dr. Ashwin, do you use this NIR fluorescence always, infrared fluorescence, this fluorescence angiography?
No, we don't have it actually, sir. We don't have it.
But if you have the facility, would you like to use it?
Yes, of course, we would use it.
Do you think it's really helpful? Is there any robust data which suggest?
There are some early data. Few phase 2 trials have been published using ICG. It is showing some incidence of the revised anastomosis better and leakage maybe marginally less. I think it has more importance in obese patients where the mesenteric vessels are not seen clearly. So if you look at the West, all this data has come from the West. There, it definitely, the mesentery is really full of fat and you really can't see any vessels there. So there, ICG definitely will help. In our group of patients, we are fortunate to have little thinner patients and we can actually see the arcade and you can see the bleeding vessel. So my dictum is that if you're seeing blood at the vessel, then the ICG in the blood also can be seen. So yeah, if you have ICG in a fat patient, definitely use it. Otherwise, if you're able to see the arcade and see a bleeding vessel at your proximal edge, maybe not required.
So actually, if you look into the literature, and there is only one this phase 2 trial, this pillar 2, or some retrospective data, which suggests that it may be helpful. But if you go for just like there was a trial pillar 3, which was stopped not at the before it ended. In which there is no difference in the leak rate. There is no benefit of using fluorescent angiography. This was only, phase 3 trial, it was not completed actually. It was stopped even before it was completed. But it is whatever data they had, they were showing that it was not beneficial. And moreover, if you go for other literature also, everything is shown that it may be having some benefit in low anastomosis in the pelvis. Only there it can be of some use, otherwise there's not a much use. To take the answers of, there's only one RCT is going on intact, which is right now it is going on, which has, I think this will come out with some answer, whether it is really benefit or not.
Yeah, at present, all the literature says that there is beneficial as even pillar 2 Actually, Kim has a large series, and he has shown what some like 7.5% prevention of leak, and so many cases he has to do revision following ICG. But so far at present, yes, ICG is helpful in preventing leak, and certain percentage you have to revision of the stump actually at present. But we had our own data, and one of our postgraduates, he did a RCT. I mean, this comparative study between with and without ICG, and we have come to the conclusion not much useful. Okay. It is not probably like only we have used in 30 cases. We could not come to a positive approach for ICG in our setup, as Dr. Aswin said. So if you are doing a proper work, only by where it will be very useful if a thin patient already is having albumin level low, and even after dividing the colon, you feel not much bleeding. Says you have some those patients, even after you keep some time for the outside the abdomen, the color changes. So you may be worried in that cases. But the problem is after giving ICG, you should need a proper scope to differentiate. Just if only vaguely if you show, you can't differentiate. It should be clearly show. It should be a clear monitor and clear scope should be there.
Yeah,
that is the important
very
thing.
important.
Not in all cases.
Important point here is
yes,
how much distance your scope is. How distant the scope is from that area, because sometimes it is too close. Even the ischemic area is also shown as having color.
Yes, yes.
And if it is far away, even the vascular area is not able to show the color. So it is very, very important how far the scope is away from the tissue.
Yes.
This is one very important point. And this is a question to Dr. Kayur. Do you do air leak test in all your pelvic anastomosis?
No, we don't do any leak test, and we just check the donuts. We always check the donuts of both the sides. But if we find the donut is incomplete or something, then we try and definitely relook the anastomosis, especially which is ultra low, from below, because we have scopes within the theater as well. So we try and see, and if it is possible, we resuture, and then definitely we divert with the stoma. But we don't do air leak test anymore.
But because even if the donut is complete, you can still have air leak. So I think
can
this
have
of
some. You can. I agree that even after complete donut, you can have some minor air leak. But anyway, all tralo we always divert. We always divert.
No, like Dr. Rajavandan said, they are not going for ileostomy in any of the cases. So isn't it very important at that point of time that you should have a air leak test? Dr. Rajavandan,
we always do air leak test.
Okay.
By doing air leaks, nothing wrong actually.
Nothing. Yeah, it doesn't take much time.
Yeah, but if as you said, if it is ultra low, if air leak is positive, or if you're suspecting something, as you can suture from below and do a diversion.
Okay. So what do you do? I mean, if you have done an anastomosis, you have air leak. How do you proceed?
Yeah, air leak. This depends upon where the entry, where the hole is. I mean, a leak is coming from anterior, posterior, lateral. Whether it is a high anterior section or low or ultra low. So ultra low, you can't do anything. How many centimeters? So if it is obviously ultra low, then you can do transanally, where you can take a suture, 1 or 2 interrupt sutures to 20 periods and do a diversion. If it is high, so what you can do after that, you can use the used stapler, you push it inside, so it will come up. So anteriorly, you can suture it. If laterally also, you can put a suture. Then again, you can divert it. Or if you are confident that if suture is taken, to do the air leak test. If it is negative, you can come out without ileostomy also. But I feel once you have a leak after anastomosis, there is chance it can become because of the ischemia something. So you do a diversion. And if it is low and it is still, if it comes out through a laparoscopic, if you can do a suture anterior and lateral, posterior, you can't see it. That in that case, you can make a suture, keep a little bit momentum over that, then do a diversion. So these are things we can do. So if it obviously, if it is a suture can be taken, you take a suture and divert. So for example, some ultra low, you can't do anything else, very obese, even transanally there, but leak is there, don't worry, just do a diversion come out and take a DT, one in this side and on the other side, so that we can give a wash and it will come out in case if it is not prepared, because all other elective will be fully prepared, so we don't bother because there not be much stool will be there. But only thing, whatever it is coming out in the pelvis, it has to come out. That should not form an abscess. That is our aim.
Okay. Nice point. I mean, Dr. Ashwin, like you said, told the importance of number of stapler firings. It's very, very important. And which size you use for the transection of the rectum?
I use 60, sir. I use 60.
60?
Yeah, I use
60 is sometimes very difficult, particularly in male pelvis.
Yeah.
If you start putting 60, the number of firings are much more. If you use less size,
45.
you can do away with the, one or two staplers.
Yeah, so the thing is, we could use 45 as well. But when I use the 60, I always try to take it in two, because almost never we can get, unless you have a very thin patient, we get it in one cartridge. So I find it actually quite comfortable to take it in two and get the intersecting line in between in the center, so that it comes out in the donut. But 45 also would be fine. But I've not had any problem with 60.
I feel it's according to my experience and my kind of practice. I always use 45 because initially I used to use 60, but I used to have a lot of difficulties. What are the rest of the panels?
45 in Covidian or 45 in Ethicon?
Okay.
I'm asking you, which one?
All of
Ethicon.
So Ethicon 45.
I'll take on it. I do agree to Dr. Jain sir that initially we used to use only 60s. Then to complete the transaction, we used to use the 45 as a second firing. But now for last 4 years, we have changed the practice. We use first 45. That easily makes the space in the especially male pelvis with a lot of irradiated area of a bulky rectum space easier. And most of the time it happens that 245 it is done. Yeah. Second 60 is also not required. So we always fire now first 45. If the remaining part is a little more, then only we use 60. Otherwise, second is also 45. Always Ethicon. Always Ethicon.
Yeah.
But I use only 60. The main thing where you are firing actually. So it depends upon if it's ultra low and if you are in the pelvic floor, you are entirely your levator trana, you can see, then there is no mesorectum in that area at all. So you go only the rectum will be there. So 160 with one next to 45, that would be enough. But so far I'm using only 60 as we was using. But I was told there, but I have not used. But I am comfortable with this 60 itself. No problem for me. But there is a different actually. If you are using 45 Covidian, there is no much difference. The same length only. So it will be very difficult. Yes. So that depends upon your surgeon's experience, which you are comfortable, and from where you are firing and what is your purpose. So on table, we usually make one rectal vascular camp is there. So I will keep in such a way that the same way the stapler is going. So the direction, everything is important. So I will always use a sigmoidoscopy to know the lower limit, because ultra low post radiotherapy, just only ulcer is there. So make sure you have a distal clearance is more than a centimeter.
So any of the panelists can answer, which is the best port to place the stapler? Whether you use a suprapubic port or a right iliac fossa port?
I actually use the right iliac fossa port, but I put that port little lower down. Very rarely I have had to resort to the suprapubic, but I think the right iliac fossa, I think most of the cases is fine for me.
We also use the right iliac fossa port, 12 mm.
Yeah, I just want to make a point
use
here because
for the high rectal anastomosis, for high, not low AR. For high AR, we can use right iliac fossa, but for low AR and ultra, I always go for a suprapubic.
Even in my subjective feeling is that if you're using the right iliac fossa port, the chances of using 60 cartridge is much less. From right iliac fossa, you cannot manipulate the 60 mm cartridge. So if you're using 60 mm cartridge, I think it is better to use from the suprapubic port. Any comment on that?
Yes, I agree. For right iliac fossa, it will be actually difficult to go down actually. So
Yes.
it will be hindrance.
Mhm.
So many times. So going down and you have to more, even if the flexi endo-GA, it is very difficult to go very down with the right left. If you have deep down, you have to go from supracortical.
Actually, there was another very good video I had about making a colovaginal anastomosis. Incidentally, my resident inserted this
And well,
end-to-end stapler from the vagina and made the colovaginal fistula. I had a very good video. I wanted to show how we corrected it then and there only, but unfortunately, I'm not able to show that. So it is very, very important to look for the vagina also while making an anastomosis. It is very, very important that you have separated the entire rectum from the vagina, and you have to double check that your resident, whoever is standing on the pelvic side, is inserted the stapler right place actually. So this is also one of the very important point to avoid any complication.
Yes, yes.
Incidental
holds some-
colovaginal fistula.
yeah, that holds merit, especially when we are operating a patient who has already undergone hysterectomy.
Yes.
Then,
absolutely right.
in presence of intact uterus and female genital tract, it's relatively less difficult. But especially only in presence of vault, it is a difficult situation to separate the vault from a radiated rectum. That makes it a little difficult.
Now about the colorectal leakage, I mean, in the post-operative period, how do you anticipate the patient might be having any leak? If the patient, nothing is coming from the drain, and what are the points you think that patient might be having leak, Dr. Ashwin?
Yeah, so usually the patient is going to have some signs of sepsis, pelvic sepsis. There is going to be some perianastomotic collection. Not always it will come out in the drain. So if the anastomosis is low, I think the first step is to do a PR and feel, gentle PR and feel the anastomosis. If any doubt, do a CT scan with rectal contrast. If patient is having fever or lower urinary tract symptoms also, then we can see the leak very clearly. We always give a rectal contrast when we look for the leak. So localized leaks, usually especially when they manifest after third or fourth day, then they are usually, especially if the patient is diverted, they can be managed by IR drainage. Generalized leaks, of course, they require re-exploration.
So actually, there is a very good modified Dulk scoring system which has given very good importance to 3 or 4 points. If the respiratory rate is more than 20, the patient is having an obvious clinical deterioration, and there's a pain in the abdomen away from the site of wound, or if the CRP is more than 250. So if you keep on adding these points, the positive predictive value and the negative predictive value increases. So if you look into these points, there are chances that you may detect the leak earlier. And in fact, there are some people who are doing regular CRP level test on 4th day, 3rd day, 4th day, 5th day. And if the CRP is raised, then there are chances that the patient might be having leak, and that even if the patient is not having obvious clinical signs, they do CT scan on 4th day if the CRP is more than 130 or 140, and they detect the leak earlier, and before the patient goes into full-blown sepsis, they have a corrective measure.
Dr.
Any
Jain,
comment on that?
Dr. Jain, Dr. Kanagwal is playing your colovaginal video.
We have got the video running, sir.
Which
I'm
one?
just playing the colovaginal anastomosis.
Okay.
Okay.
We can see that.
Okay. You're able to see that?
Yes, sir.
Okay. So, okay.
We just finished seeing your video, sir, how you disconnected back and how you refashion the repeat colorectal anastomosis.
Okay. So, and coming back to my original question, so any of the panelists, they use regular CRP levels on day 4 or day 3 or day 5?
Yeah. So what, well, the patient is having mild tachycardia and second, third post-operative day, then you suspect it. Patient may not complain, but there may be some like a bloating sensation, some unwell will be there. So the persistent tachycardia, then you suspect. But usually all our LAR, lower, ultra lower, third day we are doing a rectal contrast study to make
regularly in all patients?
early, yeah, all patients without area study patients. We do a rectal contrast study third post-operative. But CRP level, no. Only if you are suspecting. But if you are suspecting, then we do the rectal contrast. The persistent tachycardia. So immediate, even first day, second day, it started. Yeah, just tachycardia. That is the only sign will be there most of the time. Because all clean cases, even if it is whatever collection there, it will be coming through the drain. So once the drain is the leak is there, then immediately we not do that. We go and do the area study. If, as you said, there is no collection, or if the collection is not coming through the drain, or drain has displaced, it's not in the pelvis, then the patient will have definitely tachycardia will be there, lower abdominal discomfort will be there. Then you do just rectal contrast, you will find that. So it's actually finding the leak is actually early most of the time. Yes.
Yeah. Any the comments on the rest of the panelists? Whether ever is it okay to go for rectal contrast CT scan every time in all patients, even if they don't have a sign of sepsis?
I mean, probably they are not doing a diverting stoma, so probably that's an institutional protocol that they have made it to avoid the stoma. While we are dealing with diverting stoma in every case, so obviously we will do a loop cologram before we close the stoma.
So even if you're not doing ileostomy in all the cases, I mean, even if you have a policy that don't do ileostomy in any of the case, even then, is it okay? I mean, what do other people feel? I mean, Dr. Ashwin, what do you feel? Should it be done?
The thing is, if they're not doing stoma for any case, even the low anastomosis, then maybe it may be wise to check maybe third, fourth post-op day to have a look. We have started actually using CRP because a lot of interesting data is coming up as a negative predictive value. So what we are finding out is that majority of the patients have some ileus or something, and the CRP is more or less borderline. So even though the CRP is there, we end up doing the scan actually.
So CRP doesn't mean that only leak. There may be some wound infection also, CRP will be elevated. So there are some chest infection can be elevated. Some urinary tract infection may. So it doesn't mean like that. But of course, it is just give another point, that's all.
Okay. So, I mean, once there's a leak, how do you manage it? I mean, do you always go for the re-laparotomy or do it with some conservative management or some endoscopic stenting or some intrarectal drainage? Dr. Kayu, what do you do? I mean, do you do according to the situation? Have you ever done this endoscopic stenting?
I just lost the connection in between. If you can repeat the question, sir.
Yeah. The thing is, once you have a leak, so how do you manage it? I mean, do you ever use this endoscopic stenting or a local intrarectal drainage for localized leaks?
No. For all the lower anterior resection leaks, sometimes we may have to go in and do a lavage if it is a peritonitis or there is no localized sepsis which can be dealt with, say, IR drainage. But otherwise, in general, I would say if there is a localized abscess, we drain it with IR. And if there is a significant peritonitis, we always put a laparoscopy or laparotomy and lavage and do a proper diverting stoma. If it is the anastomosis lying completely open, we put a couple of tucking sutures and leave it behind in the pelvis, the natural way of healing, and it will heal eventually over a period of time. But we have never tried any endoscopic or colonoscopic devices, not even clips to heal the anastomotic site. Once it is leak, it is leak. It's not going to hold anything.
Dr. Pradeep, sir, we just showed the video of the re-laparoscopy for anastomotic leak and your hand-sutured closure of the perforation.
Perforation.
Okay. Thank you, Dr. Kanaval. Thank you. And rest of the parents, what do you think? Have they ever used, Dr. Rajapanda and Dr. Ashwin, have you used endoscopic stenting or a local intrarectal drainage? Because I
No,
think
not really.
they
There
don't
is
much
no-
of help.
Yeah. No, in the endoscopic. So when there is a leak, immediately go re-laparoscopic, just give a wash, thorough wash, and keep a drain, drain, just come out, don't do anything. Because
Or
all
any
men
intrarectal drainage from, if this is localized extrapyramidal
So
leak
that
is there.
what happens, just do a PR, just give a wash from above. So that what I feel, few cases which we get that there was a prolonged time for them for the recovery if you do intralap, because all our cases are fully, pre-operatively fully prepared patient, bowel prepared person, nothing is there. And before going, we are doing a rectal wash also, before stapling also. So it's very unlikely some fluid is coming. So we need not push it and make a hole bigger size. So that's why I just do a PR, gentle PR, that's all. So if you feel it's very low and if you're giving the wash through the pelvis by doing PR, if it comes out, that's okay. So still it comes clean, you just give a wash across the pelvis. Still nothing is there, clear water is coming. Then you keep a two drain, one this side and one the other side. So this is in case something is collecting, you can just give on one side and it come through the other end, the other side of the DT, it has to come. So after diversion, it has to be. So as I said, just allow the leak to heal on naturally. So lateral, because if it is small leak, it will not form any stricture. So later, so after 3 months, before going for eostomy reversal, still we do a rectal contrast, do a sigmoidoscopy. If you feel some leak or bigger opening is there, in that case, I have used once a TAMIS to suture intracorporeally, intraluminally or transanally. So just suture it, then you after a few weeks, then you go for the diversion, ileostomy post. But we never use any endoscopic technique. There is no need.
Fair enough. So, we have already taken so much of time. The last thing which I am just going to ask about the LAR syndrome. So, Dr. Ashwin, how often you see the LARS after doing a low anterior resection? How often you see it?
Yeah, we see it in nearly 70-80% of patients. If they come on follow-up, all of them have some amount of low anterior resection syndrome. So they need a lot of counseling. There's a stepwise management for these patients. Of course, we look at the how well the patient is coping. We start with diet and antidiarrheal agents, and then the patients who have really severe symptoms, we resort to rectal irrigation. More so for the ISR patients. So the patient's selection for ISR is very careful. You need a patient who is a little more dedicated to manage the functional outcome following ISR. So the elderly patient with the borderline sphincter function, we would probably go for the APR, even though we couldn't get a clear margin, because managing the LAR syndrome after that is going to be really challenging. There are a lot of biofeedback and mechanisms, but we're not using them as yet.
Dr. Jain, you are muted. Pradeep?
Sorry. I just, in fact, in my experience, in low anterior resections, I'm getting LARS in all the patients, almost all patients. Not 60-70%, it's almost 100%. Dr. Rajapandan, do you also feel like this?
I don't agree 100%. Probably as what Ashwin told was correct actually. For the ISR patient, yes. But what I feel, today I saw one patient. I was surprised. I did the ileostomy reversal just last month, last August. And today he came just for review and he was he was not complaining. Then I was worried, how many times you are passing motion, sir? 1 or 2 times only. Then I went and said, ISR colon anastomosis, beard is colon anastomosis. So just to reassure the patient, pre-operative itself. Pre-operatively, we have to make them, because they are worried, they don't want permanent stoma. So for that, then they will accept the temporary stoma. So once they use the temporary stoma, after the post-op adjuvant chemo only, we go for ileostomy reversal. That will take like 4 months, 5 months. So before going to ileostomy reversal, I always reassure the patient, no. So I will do a sigmoidoscopy myself. I do the rectal contrast CT. Then I will tell, I'll do during the chemotherapy, I will do the exercise, the perineal exercise. And I will tell the options at 1, 2, 3. So initially, after the ileostomy only, you'll be having all these problems. Initially, there will be more times, there will be perineal exploration. You have to take this. Then slowly we do antidiarrheal agents. If this is okay, then at last, then I will do the transanal irrigation, the rectal irrigation. Then they are very happy with the rectal irrigation. So in this last 10 years, I have one patient, young fellow. So he could not tolerate, then we have to revert back to the APR for a APR. I mean, like a stoma for the ISR. But none of the patient, and I agree, which patient has to take for ISR is very, very important. Old patient, already there is no sphincter contraction, it's not good. Do always the anal manometry, if it is not good, don't do ISR. So you have to make sure clinically, and patient should be okay, and you have the objective, subjective evidence, the objective evidence like anal manometry. Make sure the sphincter function is good preoperatively. So post-operative during the colon anesthesia, you should not be bother about the LAR syndrome. So we have to actually educate the patient, reassure the patient, this is the way, whether you want this or permanent stoma, then they will accept. So you don't bother passing motion 4-5 times per day, or you want a permanent stoma, then they say, okay, no problem. So that's why even the recent literature says everybody was happy. Those who are, they don't mind even having a pamper and doing night. So they don't. That's what they say. 90% of the patient, they accept the way the change in their bowel habits post-op. So that is the one we have to do reassurance. So
what are the steps? What are the technical steps you take to decrease chances of LARs? Are there any? I mean, some steps. Some surgical points.
I do the surgical point in ISR only. I do partial. I don't do subtotal or total ISR at all. So I will leave most of the intense sphincter. So such cases only I will do. So I will do. So all my ISR are only partial. Very only few cases, 1 or 2 cases. Subtotal. Never did a total ISR. So total ISR, it is like definitely there is a problem for patient. So this is the step.
Does the pouch make any difference? Whether you want to do a straight anastomosis or a pouch? Does it make any difference?
No, we never do a pouch. I never do a pouch. It is mostly straight. Now I am planning some few cases we are doing end to side. So most of all my LAR will be end to side anastomosis.
Okay.
So that itself will decrease the LAR syndrome. And the coloanal mostly will be end to end. But we have to reassure the patient.
I think the difference the pouch make is not artery part also. But if you follow the patient for a longer period, whether you're doing a straight anastomosis or a pouch,
there is no difference.
It doesn't make any difference. It's only for 6 months is important. Dr. Ashwin, Dr. Kayu, do you want to make any comment on that?
Yeah, we don't do pouch also either. I think the first year, after the first year, the function is better. But afterwards, the delayed function, if the pouch is a little too big, then they have evacuation problems. So that becomes even worse than the functions of the benefits that the pouch has. So we are also doing straight. My ISR, actually, I do end to side because that keeps most of the mesentery outside the anal sphincter. And we have a lot of young patients who have very high sphincter tone. So I think that decreases stricture rate, but objectively our data has not shown that.
Okay, Dr. Kayur?
I partly agree to Dr. Pandian what he has rightly said, that once you explain the patient that permanent stoma versus a couple of frequencies, eventually they accept. But I do had to convert one of my patient, 3 years before, a young chap, good anal tone, but like he was having 6 to 7 frequency despite all the measures of low motility agents, so isabgul and all that, but he could not control, and he was doing some job which was not feasible. We had to convert to a permanent stoma. Otherwise, they accept over a period of time. They have a frequency of around 3 to 4, and they accept it.
Any benefit of sacral nerve stimulation? The patients having severe LARS.
So literature says there is a sacral nerve stimulation can help in a severe LAR syndrome. That too only 50%. Long-standing, not much help. Now the posterior tibial nerve stimulation has come, which is more easy and simple. But we have not tried. We have not tried in our
We,
So,
we,
Dr.
we do
Dr.
have,
Jain, Dr. Jain will have to conclude now.
no, I was just about to say this, Doctor. I was just this finished. My
Yeah.
discussion is almost finished.
Okay.
So I thank everybody for very nice interaction. So I give it back to you. Over to you, sir. Now you can.
Thank you, Dr.
Thank you,
Pradeep, sir,
Pradeep, and
President.
thank you all the faculties for wonderful participation. We had few questions from the audience. Let me ask that. One of the question was, which is the most common complication you come across following laparoscopic colorectal surgery? To Raj and then to Kayur.
Commonest complication.
Yeah.
Commonest complication, just we can say like wound infection only. We can't say anything else other than the wound infection. Commonest complication.
Maybe if you
Just,
think
Next,
intraperitoneal.
then you have to think of leak.
leak.
Yeah. Leak or maybe
Leak is-
bleeding sometimes.
Yeah, next bleeding comes.
Yeah.
Yes.
Bleeding is, I would say, even little lesser than leak.
Yes. Leak.
Bleeding
Yeah.
is lesser than leak.
And another question for doctors. What are the long-term effects of resection in colorectal malignancies? What he meant
Long-term
to
effects.
ask, what he meant to ask, I think, is regarding the results, which you already discussed in your talk. But you may,
oncological outcomes. Yeah.
Yeah.
So that they're pretty much acceptable lab versus open across all the published literature. That I think we already covered that.
and another question is, what is the success rate, means 5 or 10-year survival rate after a right colon tumor, left colon tumor, and rectal cancer?
I mean, it's a pretty vague question. We need to see a lot of.
So all these things you can see in the literature.
Yeah, it's a pretty vague
It's not
question.
technical, yeah.
Yeah, it has got
It
nothing
is
to do-
like a 5-mark question. You can go see the
Short note.
literature. It depends upon the type,
Very vague
type of the tumor, stage of the tumor, everything is different. So stage for
Biology
all
of
tumor,
the patient,
colon,
lot
rectum,
of other things. Yeah.
all those things. Yes. But
Okay.
as for this question, we can say they compared to other GI cancer, if you have colorectal cancer, they have a 3 and 5 years survival rate is
Better than
any other case of GI cancer.
Much better than any other
Better
GI
than
cancer.
Yes.
Yep. And one question for Kayur. What is the advantage of medial to lateral dissection over lateral to medial in right hemi?
I would say not only in right hemi, but in all the colorectal procedures, now it has become a standard of care that one must always do the medial to lateral before handling the tumor or a diseased colon. It is always preferred to do a vessel first approach this is a pretty standard of care now.
Yeah.
For all colectomies, I would say.
If you are using laparoscopy, mostly it's like a non-touch technique, the Turnbull
Non-touch
technique,
technique.
non-touch technique. That's
Even
why
in
go for
open
medium.
also now we have shifted to
Open also
same.
medium to that.
Shifted to shame from medial
So
to lateral.
because you go for a complete CMV with CVL,
Yes.
central vascular ligation.
So I think that concludes all the question. Wonderful discussion we had, and I'm very pleased to say that we had more than 600 delegates watching on different platforms this program, and the credit goes to you for wonderful lectures and wonderful discussion. Kanagwal, over to you.
Thank you, President. May I have the honor of inviting our Honorary Secretary, Dr. Ishwar sir, to give his vote of.
Can you see my slides?
Yes, sir. We are able to see you and hear you well.
Okay, thank you, Kanagwal. I think all of you will agree that we had a very interesting and engaging talk by the 4 experts across the country. And dear viewers, Doc Plexus, thanks for joining this Blackbuster 13th edition for this year. And on behalf of our EC IAGS, we extend our congratulations and excellent discussions and presentation by all the speakers. And we give the each certificate of appreciation to Dr. Ashwin, Dr. Kayur, Dr. Rajabandian, Dr. Pradeep Jain for wonderful cooperation, staying till late tonight. And dear viewers, you all know, apart from this online prime time, we have been doing very many on-site programs, 12 to be precise, in the last 6 months, traveling the length and breadth of the country and meeting peoples in various laparoscopic, endoscopic platform. And that's quite heartening to see so many people participated in all our fellowship programs so far. The latest one is the robotic advanced programs done by Vivek Bindal in Delhi. And but for this Omicron, it has a different reason for us to take backseat, go into this online platform for the next 2 months. And the next class we are going to be meeting is for safe laparoscopic cholecystectomy masterclass. Please pin this date in your calendar. I am sure you will be delighted to be with us on a Sunday. And then we like to be on the onset again to have all our fellowship candidates on the June 9th to 12th in the ideal place of Andhra Pradesh, Rajamundry, wherein we are going to have 4 days of academics in 8 different halls with the live sessions. And we started booking our flights already. Please come and join us. All the faculties also give an extended invitation. Until then, we thank Doc Plexus for excellent yet another show, and all the faculties, all my viewers. Good night. Stay safe. Bye now.
Thank you so much.
Thank you all. Good night.
Thank you, sir.
Thank you.
Right.
Thank you, everybody. Thank you.
Good night.
Good night.